Okay, good morning, good evening, good late evening to all of you, depending upon wherever you're dialing from. And we all appreciate you joining in on a weekend. So for this fourth international conference on AIIMA, Artificial Intelligence over Infrared Images for Medical Applications. I am Geetha, founder CEO of Nirama Health Analytics, who happens to be the event sponsor. And as many of you know, at Nirama, we have developed a new method of detecting breast cancer thanks to AIIMA, that is using AI on infrared imaging. And today I'm speaking, just finished my talk in the second International Young Women Breast Cancer Symposium that's happening this time in India. And so there's a lot of real applications we are seeing of how infrared imaging, thermal imaging can be used to really save lives through the medical applications that's happening. So I remember, it was in 2022, June or so, I met Dr. Schwartz in South Carolina, and we were discussing about how infrared imaging has different kind of responses from people, and it's so useful, non-invasive, etc. But still, it's not used in every hospital. I feel every hospital needs to use, infrared-based equipment, and should use this to diagnose many diseases early in a preventative manner. But when we were discussing with Dr. Schwartz, whom some of Robert Schwartz, some of you may already know, he used to be the chairman of the board of American Academy of Thermology. And we said, okay, we need to sort of create some kind of objective way of doing things, objective way and so on. And I was passionate about making it really acceptable in the original or what is called as the clinical system, the traditional or the accepted, clinical system, medical radiology and oncology system that exists today. And I believe one of the biggest way to do it is making it more objective, making it more scalable, and so on and so forth. Again, on behalf of the organizing committee, that's how the AIIMA got started off. Now it's the fourth year. I'm very, very happy to see more and more participation coming in. And on behalf of the organizing committee, I welcome you all to this wonderful continuing technology conference. Many of you do know that AIIMA really is trying to combine the best of both worlds, best of the computing world and possibly best of the imaging world for the best domain where you can create the maximum impact. Of course, we know infrared imaging is radiation-free, completely safe, non-invasive. Many cases, we make it privacy aware, no touch, highly sensitive, small tissue activities can be detected with 0.02 Celsius, Fahrenheit kind of changes in the tissue. And most importantly, it is an affordable and a portable equipment which can be used to make healthcare equitable. But the missing piece, in my opinion, and many of our organizing committee's opinion, is to reduce the huge knowledge that is needed to interpret it. Reduce the cognitive load that is needed to interpret this, because we are looking at color images and our eyes have limitations, and that's where AI can come in. How can we use the newer technologies that are coming in, the AI-based technologies that are coming in, and enable quantitative interpretation, accurate results, more accurate results, putting the expert thermologist and the AI together and give better results. And once more and more of us come together and start working on different problems related to this AI and machine learning, and of course on infrared imaging, we have to make sure that our solutions will also work together. So this time we have brought in a new element of how can we make it interoperable. For example, DICOM system or, picture archiving system, it support DICOM protocol is the way to make it interoperable between MRI, CT, mammo, etc. And can we do the same for thermal? So we have a paper on that. And how do we make it scalable? Because obviously, faster we do, better accurate it is. More number of people with just simple medical knowledge or regular medical knowledge can start using it. So more number of doctors will start using it. And also, maybe even at a thermographer level, we can reduce the skill due to some of the technology. So what AIIMA tries to do is to bring together the three types of expertise that is needed to build such systems in the future. This is a whole new technology era or area that we are creating, right? So we are bringing together medical experts, clinicians, doctors, as we call them, AI researchers, data scientists, AI engineers, and also infrared imaging experts, right? And we believe some of the medical equipment manufacturers are also part of this call today. So this is a forum to bring them all together, understand the latest happenings in this field, and build this area of domain of work itself as a research and enhance it and make it more and more better. So the mission is to accelerate adoption of such innovation, which is driven by AI and II, that is infrared imaging, build this community, to foster this network, which is just dedicated in creating that clinical evidence, creating a body of resources. You know, if you see the first three AIIMA, we have a book. It is published by Springer, LNCS, you know, which is very, very well reputed scientific material, journal is created, right, with all of your papers. It's nothing to do with Niramai, you know, it's nothing to do with business. It's about creating this research area for mainly to inspire researchers, newer future researchers, young researchers to take this up. And we want to make this another Mikai, you know, it's already famous for medical imaging and machine learning and medical imaging, right? So similarly, can we have a mini Mikai, you know, where it's completely focused on infrared imaging? That is where we want to do. And at the end, we really want to make equitable healthcare. So that said, let's see what we have today. Today, we have excellent keynote address coming in by Dr. Prathosh, whom I have known as a friend and colleague in my previous organization. And I've heard his talk. He makes it really, really simple to understand. And this time we thought, you know, we've seen a lot of papers, you know, using deep learning and so on, but everybody knows what has happened in the last 2 years and maybe 1.5 years more and more with the GPT and other models, LLMs coming in. So we thought, you know, we'll go with a tutorial style talk on Gen AI so that, you know, all of us can get inspired and get ideas on how we can use Gen AI in our own applications or newer applications to make better AIIMA applications, right? So that's the idea of giving. It is not going to be with IR. If you remember previous years, we have actually done like literally tutorial style on infrared imaging. What is infrared imaging? How does it do it? Similarly, we want to do like a tutorial style on the latest happenings in the AI domain. And that is going to be the keynote by Dr. Prathosh. After that, we have research presentations, which will be split into 3 sessions. First session would have 5 and next 2 on the data set and the DICOM I mentioned, and then the 6 you know, papers in the 3rd session. And there will be some small breaks, or whether there is a break or not, you know, we encourage you to use the Zoom chat direct or in the group to create your own contacts, you know, say hi, exchange your email IDs with each other. And if you want to collaborate, you're definitely welcome. So first we will start with the keynote session on generative AI in medical imaging with Professor Prathosh. And then we have the 3 sessions. Session 1 will be chaired by, again, dear friend and colleague, ex-colleague, Dr. Vaibhav, who is now at Google DeepMind. And here we will talk about, we will hear from researchers on interpretable and feature-driven AI. Like, you know, so we are looking at feature-driven infrared imaging. Second session will be led by my colleague and co-chair of this conference, Dr. Shiva. Many of you would have heard from him. He's the one who did most of the work, and you know, so he's going to chair the second session, and the third session will be chaired by Professor Orofacial. You know, I think who's her student many times. You know, have been part of the AIIMA by presenting excellent research papers, and she has kindly agreed to chair the session 3 on deep learning and Gen AI. So Here's some quick view just to sort of, if you have not looked at the agenda, I'm not going to go through every paper, but you can see like it's not about high level, high AI and so on. It is going to be real deep machine learning, talks that is going to come up in all the three sessions. Let's get started and be together. Let's together create this new area of research on AI over infrared imaging. So to start with, let me introduce Dr. Prathosh, Professor Prathosh AP, who is now an assistant professor in Indian Institute of Science, which is one of the most premier institutes in India, who is going to talk about generative AI in medical imaging. Professor Prathosh, in addition to being an assistant professor in IISc, he is a co-founder of Cognable Tech, a new startup which has received a lot of recognition and accolades from the government as well. Just a new one, but already a good recognition for starting off with this new technology for AI-driven behavioral kind of insights. He holds a PhD from IISc in temporal data analysis. He used to be an excellent researcher at Xerox Research, where I have known him very closely. And then he used to work at Philips Research before that, and then after that, and then also had another startup, working with the healthcare startup in California. He holds 10 US patents granted and many more pending grant. And he's known for his extensive research contribution in artificial intelligence, machine learning, signal temporal data analysis. But most of all, he's an excellent teacher. So let's welcome him. I'm assuming Prathosh is there, and I request you to share your screen and would love to hear what you have to share. Are you there, Prathosh? Shiva?
Yeah, Prathosh is here. Yes.
Yeah, Prathosh, you can start
Can
sharing
you
your
hear
slides.
me?
Yes, Prathosh. All good.
Okay, I'll do that.
So
Okay.
if you have any comments or
Yeah.
questions, please use the chat to share your questions. We will take the question at the end of the talk. Okay, Prathosh, over to you. Stage is yours.
How much time do we have here?
Sure.
We have 45 minutes session. Yes. 45 minutes. Okay, good.
Yeah.
Okay, so good day, all of you. Thank you very much for the opportunity of inviting me here in this prestigious conference, and it's a pleasure to be here. So I should thank the organizers, Dr. Geetha. To those of you who do not know, she was my first manager when I started working formally after my grad school. And yeah, Shiva was my colleague, and I see my friend Vaibhav also here. So yeah, it's an honor to be speaking in this august audience. I think Geetha set very high expectations, so I'll have to live up to that. Let me see what I can do. See, as I was told, I have prepared a talk around the current state of what generative AI is, specifically applied to clinical medical images and clinical data. So I'll give you an overview of what kind of techniques are around and what is the general principle, what are the current capabilities of these models, and what are the possible pitfalls that one should be looking at when using them for applications such as medical imaging. So that, and then finally I'll talk about a few thoughts that I have. See, I also happen to be working with a lot of clinicians across the country. I don't work specifically on infrared images, but I've been looking at histopathological images, radiological images, and so on, and I'll share some of my experiences while using these techniques on these sort of data, and we'll see what sort of things that one can do going forward to address some of those challenges. So that's how I have positioned my talk. Let me just share my screen and then video. Shiva, I can't share my screen. It says only host can share. So I think you should enable.
Can you make him host?
Yes. Can you try now, Professor Prathosh? Yeah, hold on. No, I can. Give me a minute. I hope all of you can see my screen.
Yeah.
Okay, so yeah, feel free to just stop me at any time if you have any questions or comments. Yeah, so this is the title of the talk. I'll be talking about generative AI for medical applications, clinical applications. And as she already introduced, I'm Prathosh, right, currently a faculty member at IISc Bangalore. So first of all, we'll have to see what is the, I hope my slides are visible, right? I mean, you can look at the text here.
Yeah.
Okay. So the first thing is, why do we need generative AI? As Geetha rightly mentioned, now it's ubiquitous. I mean, you can see generative AI in almost all walks of machine learning. The use of generative AI is more relevant in the problems such as healthcare and other areas, because of the problems that we encounter on a daily basis. Yeah, the one big challenge that all of us face when we are trying to do something with clinical data is the non-availability of data, the so-called data scarcity problem. There's a lot of rare diseases and annotation is costly. I keep saying this, unless in the areas where you can have non-expert annotators annotate data for you. Clinical research is one field where annotation costs a lot of money because you need experts to be handling those annotations. So lack of annotation is a big issue, all of us know that. And there are privacy constraints. There are GDPRs and HIPAAs of the world, which where you don't just want your model to be doing something, but you also want your model to be interpretable, explainable, and so on. And even the modalities have acquisition cost and time. So MRI scans are very costly, at least in country like India, and they take a lot of time. So one can use generative AI in solving most of these problems. So there are these clinical workflow bottlenecks as well. So that in a country like India, there is a humongous shortage of expert radiologists, and that's why that's the problem that companies like Nirama is trying to solve. So there aren't enough expert clinicians in the ecosystem, and how do you cater to everyone in the country is another question. And you can reduce the reading time, and there's also this inter-reader variability and so on. So now our belief, I think all of you in this community believe that generative AI can be used to solve, if not all of these problems, some of these problems very, very effectively. So quantitatively, impact potential is that you can reduce the data acquisition time, and augmentation time. Data acquisition time can be reduced, and to address the problem of data scarcity, you can generate new data. I mean, that is one of the signature use cases of generative AI, where you solve the problem of data scarcity by simulating or generating a lot of synthetic data. Theoretically, there is no limit so as to how much of data can one generate. So you can augment your data set by 100 times if you want. And there is cost reduction up to 30 to 40%. And one can also think of radiation dosage reduction. Nirama is one classic example of it, where the entire exposure to radiation can be taken off. So I think there is a clear need and relevance of generative AI, especially in the area of healthcare. We all agree on that. Okay, so now given that we know that generative AI is something that is useful, before we deep into some of these techniques, let us look at a broad taxonomy of the existing generative modeling landscape. So if I were to classify these generative models into some buckets, this is what I could think of. There are class of methods called likelihood-based models. You might have heard the word the models such as variational autoencoders, normalization flows, autoregressive models, and so on. These models fall in the category of what are known as likelihood-based models, where given some data, you would compute the likelihood of that data under the model and create bounds on the likelihood and try to find the model that would optimize or maximize the likelihood. That is one class of models. There are other class of models that are known as implicit models. You might have heard of names such as generative adversarial networks or GANs, and there are energy-based models where you use the Gibbs distribution to create a generative model for images. These sorts of models fall into the category of what are known as implicit models, where the likelihood of the data will not be explicitly estimated, but they'll be implicitly estimated within the model computation itself. The other class of models that are very, very powerful and contemporary and being used almost everywhere in generative, especially image generative applications, are what are known as diffusion models, where the idea is to construct Markov chains or random processes to start from a noisy image and go on to sample an image of interest. So these sorts of models are called diffusion models, and a subfamily of those models are what are known as core matching models and stochastic. I mean, they are all based on this idea of stochastic differential equations or SDEs. Now, most of the commercially available image generators, you see all of these AI chat interfaces that we see today, including GPTs and Gemini and Claude and all these, they are capable of generating images. Most of them are using this modality called diffusion models because of their versatility and so on. And there are also these class of models that are based on transformers. So transformers are not actively used for image generation particularly, but for other modalities such as text, code, and other kind of data, transformers are the go-to models. The examples include the vector quantized VAE, transformer-based attention mechanism-driven models such as uh, GPTs and BERT and so on. So one can also look at task-specific categorization. So if one were to look at synthesis as the task, the models that are typically used are GANs, diffusion models, and VAEs, and there will be a lot of translation tasks that clinicians do, which is you want to go from modality A to modality B. Let's say that you have an X-ray and you want to convert that into an image that would look like if that were captured using an infrared camera, so converting between modalities. So for those kinds of applications, people use what are known as cycle generative adversarial networks and pix to pix and so on. If the task is about reconstruction, which is you want to do tomography or different kinds of image reconstruction, you use diffusion models. And for segmentation tasks, which is another important task in clinical research, people would use models such as conditional diffusion models, conditional GANs, and so on. This is the broad taxonomy of how these models work. We will look at each of them individually at a broad level and understand their advantages and disadvantages as we move on. So I have a couple of slides just to give you a deep dive of what is the general principle of working of generative modeling. This can sound a little pedantic, so apologies if it sounds that way. But yeah, so I've tried to make it as accessible as possible. So mathematically speaking, I know that there are a lot of clinicians that are there in the audience. Please bear with me for a couple of slides. If you are interested, this is the general principle that would put all the models that were just discussed under one umbrella. So the general principle is as follows. What you start with is what is known as a data set, right? For all machine learning, we start with what is known as a data set, which is what I have represented by the letter D here. So you have n such data points. So x1, x2, x3 up to xn are all images. So they can be images or they can be time series, and they can be text. It doesn't matter. So this is data agnostic. The treatment here is data agnostic. What you start with is a set of n data points, so that constitutes your data set. Now, mathematically speaking, we as generative AI practitioners would call all those data points as coming from an unknown probability distribution. That's what is being represented by the letter script px here. You see a px here. So px, think of it like a function that would completely specify the characteristics of the underlying data set. Okay. Now, given these data points that are drawn, as it is called, that are drawn from an underlying unknown probability distribution. By probability distribution, I mean a function, a mathematical function that would specify the characteristic of the data set that we are dealing with. Now, what we have are some samples from that underlying data set. What we do not know is what function generated this data set. Okay, so that is the setup that we deal with in generative AI. Now, if I have to give a very primitive example, think of it like somebody is tossing a coin, and that is the generative process. And this coin is a biased coin, which is that it does not have the probability or likelihood of heads to be equal to zero point 0.5. It has some other probability of turning on head. So somebody has given you a sequence of coin tosses as head, tail, tail, head, tail, head, or something as a sequence of toss. What you want to find out is what is the underlying function or the characteristics of the coin in this particular example that gave rise to this sequence. Okay, so you can extend this primitive example to almost all the generative AI problems that we encounter in practice. So these, I mean, just like you have a sequence of coin tosses, you would have a sequence of images. So every image is now seen as the outcome of a coin toss. What we are interested in is knowing what is the underlying generative process that is represented by this letter px mathematically that gave rise to this particular data set. Now the idea is that if we can somehow model the underlying generative process, if we completely understand what the underlying generative process is, perhaps we can generate more data from that underlying process. Now, that is mathematically referred to as the process of sampling. So if I were to go back to the example that I just cited, given that I have a sequence of coin tosses, if I know what was that particular coin that gave rise to this sequence of coin tosses, I could generate more outcomes from that particular random experiment that gave rise to this sequence is the idea. Now, this is, I mean, I have tried to formalize this idea in this particular slide. So the general principle of generative models is as follows. Given that we have a few samples that are given from an unknown probability distribution, the function that is generating the golden ground truth that is generating the data, the goal of all generative models is to estimate that underlying function that gave rise to this particular data and also learn to sample from that underlying distribution. So what do you mean by sampling? The coin toss example, you simulate more coin tosses. In the case of clinical images, you generate more clinical images that look like the real data that we have. So here is the general principle with which it works. Okay, I mean, again, this gets a little mathematical, so bear with me for 5 minutes. The general principles of generative models is as follows. Remember that all we are interested in is estimating this underlying probability distribution, which I have denoted as px here in my slide. Okay, what people do is they start by assuming that this px can be represented using some neural network. Okay, and that neural network is what one refers to as a model. So we keep talking about this term model, right? I mean, there is this model that has a billion parameters, there is another model that has 7 billion parameters and all that. By the word model, people refer to this neural network that is designed to mimic the underlying function that generates the data. That is called a parametric assumption on the underlying probability distribution function. Now, given that we make that assumption, what is that we have in our control? Please remember that this entire problem of generative modeling is ill-posed in the sense that we have no idea about what was the actual function that generated this data. Okay, all we have are a few samples that have given rise to this particular data set that we have, but we have no idea about what the underlying function is. So then when you are dealing with a blind problem, I mean, what do engineers do? The best thing is to assume that your underlying generative function has a particular form and try to estimate its parameters. You can go back to your high school math days and relate this to the classical curve fitting problem, right? So if you are given a few data points or few points from a curve, from an underlying curve that we don't know, the job is to connect those dots in a meaningful manner that we simulate what would have been the points in the unseen scenarios. Okay, that's the idea. But for that, you will have to assume what the underlying parametric function family of your model. So what people do is represent the underlying function that you want to represent using neural networks. So now you might have this question: why neural networks? Why not assume that it's a quadratic curve or a cubic curve or a line or something? There is this very powerful result okay, which is within computer science community, that would say that these particular functions, which we call deep neural networks today, have this remarkable capability that they can approximate any function to arbitrary closeness. So what does this mean? That it means that you can take neural networks and tweak its parameters. So what do you mean by tweaking the parameters of neural networks? So let's say, I mean, all of you know that if one were to represent a circle mathematically, one would need three parameters, right? Or rather two parameters. One is the radius of that circle and the center of that circle. If you give me what the radius of that circle is and where the circle is centered, then that circle is completely specified. So just like a circle can be specified using two parameters, a neural network can be specified using, let's say, billions of parameters, which are called the weights of the neural network. So when you hear that that a neural network has 1 billion parameters, we are actually talking about 1 million weights or the parameters that this neural network have, which is under our control. So what we can control as practitioners are these parameters. So every set of parameters of this neural network will give rise to different kind of function that the neural network is trying to approximate. Now combine this result with the universal approximation result that I just cited, which is any neural network can approximate any function to arbitrary closeness, which means that perhaps there is a way to tweak the parameters of this neural network to ensure that this neural network is finally matching the generative function that that is giving rise to my data. So that's the general principle. Now, how is it done? The way it is done is that you first assume that this neural network is capable of approximating my underlying generative function, and then define what is called as a distance metric. What do we mean by that? Whatever this neural network is generating, so that generates a particular function, let's say a probability density function. There is a true unknown probability density function that is giving rise to this data. You define a sort of distance metric between what this neural network is generating and what my reality is. Now, if my real generative function is too far from what my neural network is learning, then I would tweak my parameters further to ensure that this distance between the real generative function and the function that my neural network is approximating is minimized. Okay, and that is what is fancily called as training the neural network. So all we do in training a neural network is iteratively adjust the parameters of the neural network. You just see this big ugly looking equation here, right? Theta star is the minimum of some distance metric between px and p theta, where this p theta is the function that this neural network is learning, and px is the actual generative function. So what this equation does is try to tweak the parameters of this neural network, which is our model, as long as that the distance or some divergence metric or the distance between the true generative function and the function that this neural network is imposing is minimized. This is what is called as training a neural network. And you all know that to train this neural network, you need a lot of computational power, one would need a lot of data, and those are details. In fact, the capability of this neural network to learn good functions gets better and better if you have more and more data. In fact, I keep making this comment that what changed after, let's say, 2017s and 2018s, where this generative AI just suddenly started making sense, is these principles of sampling from an underlying distribution existed decades before. People knew this at a mathematical level. But what changed is that Moore's law broke, and we started having enormous amount of compute, okay, with which we could train models that have millions and billions of parameters. The other thing that happened was the internet explosion happened, and people started having access to enormous amounts of data, unprecedented amounts of data, and combine this with the amount of compute that was available, and people used the known principles of generative modeling that were there, and because of the enormous amount of compute and the data that was available, the generative AI magic that we see today was possible. Now, this is not directly translatable to clinical research, because unlike the general purpose generative models, in clinical research it's very hard to get that the scale of data that the general purpose generative models would have access to. Okay, so this is the general principle of how generative models work. I would just spend some time in explaining some of the advantages and disadvantages of some of the state-of-the-art generative models that are often used in different applications. See, one very famous class of generative models that came in early 2013, 2014 was these models known as generative adversarial network. The idea is to build a generative model by setting the entire problem as from a game theoretical perspective, where you have a function, a neural network that would simulate or generate your data. You have another neural network that would give you signals about whether the data that was generated is correct or not. Okay, you set up the optimization problem in such a way where the neural network that is generating this data is constantly challenged by that other neural network, which is called the discriminator or the critique network, that is constantly watching this generator and trying to push this generator in the direction where it starts generating data from the actual generative distribution. Now, the name adversarial network comes from the fact that the problem is solved or cast in such a way where this critique network is not helping the generator network generate in a positive way. It is trying to help the generator network in an adversarial way. What does that mean? That means that the job of this critique network is always to undo what the generator network did, in the sense that this critique network is poised to find out whether the data that this generator network is generating adheres to the actual distribution or not. Okay, the job of the generative network is cast in such a way that it has to ensure that this critique network would fail to discriminate between what is real and what is false. So the basic idea is, if you can make your sampler or the generator network capable of confusing another network that is designed to discriminate between reality and what is generated, then you are successful. Because I mean, today this is happening, right? It is, you can think of it like a simulated Turing test, where the pinnacle of any generative model is achieved when the generative model is capable of fooling an expert fooling an expert about whether he's capable of discriminating between the reality and what was generated. So that's where the name adversarial comes from, where the entire training objective is set in such a way that the generator network is always poised to or created to fool a network that is designed to discriminate between reality and what is generated. There are lots of, this was very successful. In fact, this was the first demonstration of generation of higher dimensional data. So GANs started generating a lot of real world like looking images in let's say even in general purpose applications and also in clinical applications. So this made a lot of noise in the community that generating data from higher dimensional spaces were possible. One can use a lot of GAN-based techniques for clinical applications. One is cross-modality synthesis, data augmentation for rare pathologies, and state normalization, and so on. But this suffers from a very dire disadvantage, that training these networks is known to be very notorious, because the problem is set in an adversarial manner from a game theoretical perspective. The stability becomes a big issue. So making these networks have a stable training becomes very difficult. Now that's why these things are not state of the art today, because of their problem associated with their training. So these networks are known to be very, very unstable when one would train these networks. So there is another class of family of generative models known as variational autoencoders or VAEs. So this family of models come from this idea called encoder-decoder networks, where the idea is that given a particular modality from which you need to generate your data, the first thing that one would do is to compress all that data and project it onto another space, where the data is represented using a compressed representation. And this space is what is known as the embedding space or latent space of data. You not only learn to compress the data, but you also learn to decompress the data. So what do you mean by decompression? Going from data space to the latent space, which is the process of encoding, would compress the data onto a compact representation. But if you invert that process of starting from a compressed space and getting back to the data space, that acts like a sampler or a generative model, right? Because you know how to start from a compressed information, compressed latent space, and go to the data space. Now, these are the encoder-decoder models. In fact, this is very similar to BERT kind of models in NLP, where you learn an encoder to encode the text into a compact latent space. And from that space, you learn to decode or decompress the data, which acts like generators. Now, this can also be used in a lot of medical applications where you can use it for multi-contrast MRI synthesis using conditional VAEs, and anatomical shape modeling can be done using beta VAEs for an application called disentanglement, where you are given a particular image. What you want to do is to learn features in such a way that every dimension of this feature represent different, have different clinical connotations associated with it. This thing is called disentangled learning, which can be done using VAEs. But there's again, these models also have a disadvantage that while they can generate, while they are not as unstable as GAN training is, adversarial networks are known to be notorious while they are training, but VAEs are better trainable. But the problem with VAEs is that they tend to generate blurry images. So if you use a VAE to generate a particular image modality where sharpness becomes a constraint. I work a lot with histopathological images of different pathological cell anatomies, where the sharpness and the detailing of the generated image becomes an issue. One cannot employ VAE for those kinds of applications because while they are very good at generating gross concepts, generating very finer detailing of the images or the data that one would need is difficult with VAEs. So that's where people moved on to this new modality, which is called the diffusion probabilistic models. They're also called the diffusion models, score-based models, DDPMs. They have different names, where the idea is to employ this very powerful technique called stochastic differential equations, SDE, that comes from physics, where the idea is to learn a transformation from the data space to the latent space and back to the data space from the latent space. But unlike in a VAE, you don't do it using neural networks, but one would do it by making your data run through a Markovian chain. So what do you mean by a Markovian chain? It's a random process where you start with a particular data modality, keep adding very small amounts of noise to that image, and move to an extent where the image completely gets transformed into a noisy image. And from that noisy image, learn to undo what was just done, which is denoise the noisy image, so that you end up getting the image that you started from. Okay, that's why the name denoising diffusion models. Diffusion, because the name diffusion comes from the stochastic differential equation literature, where you have a Markov chain, mathematically speaking, where you have an image, you transit that image through a first order Markov chain to convert that into a noisy image, and from that noisy image you get back to the image domain. So if you know how to transform a noisy image to semantically meaningful images, then you would have learned how to sample from the underlying distribution, is the idea. Now this is known to be stable while training. This is also this would not end up generating blurry images, unlike VAEs. This is known to generate very sharp images, and that's why the adoption of these kinds of models are everywhere. As I said, the state-of-the-art image generative models that are used even commercially today are based on diffusion models. Most of them are based on diffusion models. These are very, very powerful. But these are not free from shortcomings. One very well-known shortcoming of this is it has a lot more computational time compared to the other model categories, and that's why if you would have noticed, when the diffusion models became commercially available a year or so before, If you would have used some of these models such as stable diffusion, if you give it a prompt to generate a particular image, it would make you wait for a long time. There is a long wait bar that comes up, and it will take some time in generating those images. It's because one needs to traverse through what is called as a reverse Markov chain that would take some time computationally. So a known disadvantage of DDPMs or diffusion models is that these models take a bit of time to generate images. However, people have come up with a lot more tweaks on the diffusion models to reduce the inference time. One example is these class of models called as diffusion implicit models, DDIMs, denoising diffusion implicit models, where the Markovian assumption that was made in the denoising diffusion models is foregone, and as a result of it, the generation quality stays the same while the inference time is reduced drastically. So what is employed today in practice are diffusion models and their derivatives such as DDIMs and so on. So there are also these class of models which are known as transformer based generative models. So transformer based generative models are the ones that are the go-to choice for modalities that are other than images. So for image based modalities, the choice of the models that are made today is mostly diffusion models, even though one can use transformer models such as vision transformers and so on for generating image modality as well. But most of the cases, diffusion models are known to be more stabler compared to the transformer based models for generating clinical images. However, vision transformers or VIDs are emerging to be an alternative for diffusion models as well. But if you are dealing with modalities that are other than images, transformer based models are the ones that are the go-to choice. For instance, all the text based generative models that we see today, including GPT, Gemini and so on, they are mostly based on the transformer architecture, which has this famous celebrated attention mechanism, where the idea is to model every token of data to be attending or seeing through the other parts of the data while making decision. Okay, so this is about the model taxonomy and some classes of models that are currently used. Now I'll spend 5 minutes on describing a few sample problems which can be tackled using some of these generative model families. One is, I'm sure that most of you are aware of this and have worked on this extensively, but for the sake of completeness, I just mention them nevertheless. So one application of these applications is in image synthesis and augmentation, which is, you address the data scarcity problems, where as we discussed earlier, most often what happens is we are dealing with a rare disease and getting a lot of data is very difficult. So what we would do is build a generative model that can sample from the underlying distribution and generate a lot of data and augment your data set using the synthesized generative data. Now, even there are two types of generation that one can do. One is called the unconditional synthesis. The other is called the conditional synthesis. Unconditional synthesis is the case where you just generate the data, but you don't care what the actual content of the data is. The example is, let's say that you are dealing with MRI images. What you want to do is just generate more MRI images without caring about what sort of particular characteristics these MRI images have. That is unconditional synthesis. There's another class of generative models, application of generative models, which are called the conditional synthesizers, where you don't simply care about generating images, but you care about generating images with particular characteristics. For instance, what you want to do is generate an MRI of some tissue with having some tumor in it. Okay, so these are the kinds of conditional generative models that are much more useful than unconditional generators, because suppose we are solving some classification problem of finding whether a tumor exists or not in a particular image. If you want to augment our data, we are just not interested in generating data from that modality, but we are interested in generating data from that modality with particular characteristics. That's called generative conditional synthesis. And most of the models that we just discussed can be very easily, trivially tweaked to sample from conditional distribution, or they can be made into conditional generative models. So the other problem that is often solved with generative modeling is segmentation via generative priors, where you have a modality, you want to find out the presence of a particular type of tissue or an abnormality in an image. What you do is use these generative models with what are called as shape priors, which are particular type of prior impositions that you do on these generative models, and these shape priors can be used to do what is known as segmentation in a much better manner, instead of just using the standalone segmenters such as unit. Right. So we also talk about the evaluation metrics. Okay, you have generated some images. So now what? This is one of the key known challenges in generative modeling, that how would one validate what that has been generated is of good quality. People are coming up with different metrics in the literature. You might have heard some of these metrics such as FIDs and inception scores and kernel inception distance and so on. While these metrics work well with general purpose images, I have seen that oftentimes these metrics do not translate or scale well to specialized modalities such as clinical images, specifically because most of these are concerned about the gross level feature mapping. They are not looking at very finer detailing. While in the clinical applications, most of the times, one is interested in not in making an image just look like an MRI or a thermal image. We are more interested in the image having finer details, fine-grained details, and characteristic that it would have if it were coming from the real modality. So one big area of concern and challenge is that the community has to come up community has to work towards coming up with metrics, the evaluation metrics for these generative models that are tailor-made to clinical images, right? So that is one very well-known challenge. These models are not free from pitfalls. One has to always be aware of these pitfalls when one is working with generative models, more so when one is looking at generative models for clinical applications. One very well known pitfall is this problem of domain shift and distribution mismatch. So what is this? What happens is that you have built some generative model using images that come from one clinical site. Now everything is working fine. Now if you were to port that model to images coming from some other clinical site, most of the times the model that does not generalize across different clinical sites, or you change your acquisition protocol, it will change, and patient population, something you have built for the Caucasian population may not generalize to Asian populations and so on. So these problems exist all the time. So these from a machine learning perspective, these problems are called covariate shift problems, concept drift problems, and label shift problems. One always needs to be aware of these problems and incorporate solutions to counter these problems by design. Okay, this is one problem. The other problem is violation of what we call as IID assumption. So what do you mean by that? In all of machine learning, one would make this assumption that the data that we are getting, that we have as a starting point, is identical and independently sampled from one distribution. So what does this mean? This means that the environmental characteristics that is giving rise to this particular data modality is kept constant and not changing, right? But what happens in medical data is that the IID assumption is broken most of the times. So what do you mean by breakage of IID assumption? Is that there will be treatment induced dependencies, and there are hospital specific systemic biases that creep into your data that would violate this IID assumption by construction. Now while these models have made this IID assumption, if you make this assumption and pass it through data that would violate IID assumption, these models are bound to fail. So when one is building these sorts of applications, one should be very careful about whether the data adheres to the IID assumption that was made. If they are not, if the data is not adhering to the IID assumption, one should think of how would we tweak these models to handle non-IID data. And there is this problem of evolving data streams, which is called concept drift. What happens is the models, the data is not static. No, as time progresses, you get new data, new diseases added, new kinds of modalities added to your data stream. So if you have a model that does not evolve over time, it would not serve the purpose that it was initially conceived for. And adding to these are the poor data quality issues, which is annotation errors, and you have the intra and inter annotator variability that you would have seen always, and there are boundary disambiguities that come up, and there are artifacts and other noises. When I was working with Geetha back in the day in Xerox, so we were working in this problem of predicting the clinical complications within ICUs. What happens is, while you are collecting data which are time series, there are missing data. There's a lot of missing data that creeps us because there is sensor losses, and somebody did not record the data, and so on. So how do you deal with this poor data quality issues? This would creep up more often in clinical settings than not in compared to the other modality. And there's also the selection bias and sampling issues, right? I mean, there is referral bias, survivor bias, and demographic imbalance. All of us know that whatever models that you build for one particular type of population does not generalize to the other. So how do we deal with it is another question. Yeah, so given this, what are some of the open challenges that are existing today that some of us can take up as our research goals and projects? See, one thing is whatever I just spoke so far, which is how do we deal with non-ID data, how do we deal with concept drift, how do we deal with generalizing across different populations, how do we deal with data if we do not have a lot of data, how do we deal with data scarcity problem, and so on. Added to that are some of these open challenges. That 3D volumetric generation is one problem that is still open. So it's very easy to generate two-dimensional images, but most of the clinical images are three-dimensional. There are volumetric images that are used in clinics in daily practice. Generating 3D volumes is still an open challenge in the community, and there's a lot of work that is coming out. The other problem is multimodal data generation, right? I mean, you all know that clinical decisions are not taken on based on a unimodal observation. So people just don't see the image and make a decision. People look at genomics and clinical nodes and whatnot along with the images to generate data. Now, if you were to build a model that would serve as your augmented data, one would have to integrate all these modalities into the generative platform. So how do you generate from multiple modalities is still an open problem. And temporal modeling is an issue. As I just mentioned, how do you model evolving data? So static data can be modeled easily. How do one model evolving temporal data is another problem. And of course, we have the problem of few shot learning, where all these models that we just talked of, they are doing extremely well in general purpose imagery because there's practically infinite amount of data points that are present for their training. But in clinical settings, you would not have such amount of data. So now, how would one handle the absence of large-scale data? However, one can, with a one can obtain small-scale data. So now the technical question is that can we build efficient and stable generative models using only a proportion of the data that would be otherwise required? So this is called the few-shot learning modalities. And there's also this problem of causal modeling. Causal modeling and causality is a big topic of research in machine learning. See, I keep interacting with a lot of clinicians. Whenever we show them a result, one question that they would ask always is that, okay, your model is doing something. Tell us why is it doing what is it doing? So people are not just interested in getting a particular result, but people are also interested in interpreting that result and explaining that result. So explainability comes naturally if you make your models causal. Most of the models that exist today in the market are not causal models. So how do you deal with causality in these models is another question. We also already talked about interpretability and generalization across institutions and so on. I actually have only one slide and then we'll stop. So if that's what you're trying to tell me. Yeah, so only one slide, so I'm keeping a watch on my time. So some future directions that one can, that all of us as a community can look at is, see, one thing that I've been talking about for a long time, I'm sure that some of it is being happened in places like Google, is build foundational models for medical imaging. Okay, so today we have foundational models for text, foundational models for general purpose images and so on. See, because this conference is specifically concerned about infrared images, I would request and urge that all of you people come together and try to build a foundational models, collate all your resources together, compute data, everything, run it through a foundational model trainer, and have a model that all of us can use. See, the way it is done today is that nobody trains foundation. I mean, not many people train foundational models. You have an open source foundational model that exists. You take it and then do parameter efficient fine tuning on top of it. So if you are trying to, Dr. Geetha just mentioned about building a community of researchers. One very concrete thing that you people can do is think of building a foundational models for infrared imagery, so that anybody who does any research later would just download that model and then does whatever fine tuning that they would want to do on top of that model. And of course, there are other directions such as generative drug discovery, and people are already working on it. You have AlphaFolds of the world and so on. And I mean, since I know what Niramai does, I wanted to put this particular idea of neuromorphic hardware, because I know that most of the things that you people do are to be done on edge. So you can't afford to place all your data, send it on cloud, because most of the places that Niramai operates in, I mean, companies like Niramai operate in, are places where getting an internet connection is an issue, right? You want all of your thing to be done on the go, using edge computing, and this neuromorphic hardware specifically for this kind of clinical applications would be a great research direction to look at. Yeah, so key takeaways, generative AI offers potential for medical imaging. All of you already know that. Diffusion models are current state of the art. I mean, one suggestion for people, I mean, some students or early researchers here is that please don't waste your time on models such as GANs and VAs and all that. Okay, it's okay for assignment kind of things. If you want to do clinical grade stuff, start with diffusion models. And clinical translation and validation, clinical translation needs rigorous validation. So one needs to think of coming up with better metrics and better ways of validating these generative models. And there are a lot of open challenges that researchers can take up, like building generative models and 3D volume reconstruction and few shot learning and so on. Yeah, so I think in a nutshell, I mean, one cannot escape generative modeling. It is going to come up. So all the the old school signal processing kind of work that we were doing will become obsolete. That's my personal opinion here. I am of that opinion that all of that will completely become obsolete and everything will be taken over by generative models. So earlier the better. So since we are talking to a community of people who are passionate about an alternative modality like infrared imaging, I think it's time that all of you come together and try, start creating resources such as foundation model building, which would help the community at large. Okay, that's it. That's all I had. And yeah, thanks for sitting through the presentation patiently. Sorry if I've bored you. So yeah, thanks for the opportunity again, and that's it. Open to
Thank you.
questions.
Thank you very much, Prathosh. I think, as usual, you were that professor who, like, every person would understand most of the aspects that you're saying. So it was excellent to listen to your talk. And it's interesting that you mentioned one of the next steps should be foundation model. I'm glad to announce to this whole team that Niramai team has already started working on a foundational model. We've experimented earlier with GANs for generating thermal images, etc. But those of you who would like to work with us to enable this foundation model across multiple such, to make like a multi. To generate a model which can be used for multiple applications, medical applications, generate that foundational model. Please reach out to me or Shiva, and we can incorporate your interests with it. So we are on the way. Thank you so much, Prathosh, on multiple things you said. There are already many questions. So one thing I wanted to sort of, I started off with the first question. I'll start with that about hallucinations. Like people, whenever they look at Gen AI, LLM, GPT, first thing is like hallucination. Of course, Vishal did say that every generative model can hallucinate. That's true, but not really like the GPTs, right? Where you can really go and make something else which looks like real breast image of thermal, but it's not at all. And things like that, especially in medical imaging, it's very, very important, especially if you use this for synthesis of data and you're learning more things based on generated images. And so you end up building a model which completely can say cancer as no cancer and no cancer as cancer. I mean, it can be as bad as that as well. So what are your thoughts on the different models and where it can really take you to the completely different space? That was the first question. We have two more questions. I know, Shiva, we are running out of time, but maybe you can give short indications of the answers, Prathosh.
Yeah, sure. Yeah, so as you rightly pointed out, right, generative modeling by construction is bound to have hallucinations. But what one can do is one can impose. So this is one of the questions that we ask and try to answer in our lab. So what one can do is that impose these very strong clinical regularizers uh, while you are constructing this model. So what you say is that you restrict, I mean, in a nutshell, you restrict these models from generating clinically nonsensical images. So now how do you do that? There are mathematical ways to do it, right? But the idea is to regularize these models very strongly. Okay. See, one way to do it is to use some of these reinforcement learning based. There is this thing called RLHF, right? Reinforcement learning based on human feedback. So just like these GPT now can be very polite with you, okay, do not talk toxic language and so on. You can make, not you can, one should definitely make these models not throughout jargons in terms of having images with wrong annotations. I think those things are possible, and that is where, see, I made this point in the beginning of the talk. If you were to make a general purpose model not throw out toxic content, it's pretty easy because identifying what is toxic or what is not toxic is easier. Anybody can do that. But if you want to make a thermal imaging synthesizer not hallucinate, then you need to validate it only with clinicians. That's where the real problem is. But one
Yeah.
needs to do it. Yeah, one needs to do it. There is no alternative to it. But yeah, there are techniques to deal with this problem.
Cool. I appreciate that, and it's very important for medical imaging. The second question is from Bharat. For conditional generation, which of the models give better control over the features we want and fidelity? So he's asking about the features that we control so that we can make
Yeah.
it explainable, for example. Anything else you
Yeah.
want to add? Yeah, go ahead.
Yeah,
Go
so
ahead.
of course, diffusion models, if you're looking at clinical imagery or image as a modality, but even when you're conditioning, if you were to have better causal control, there are techniques to make it conditional, right? And for instance, I can give you an example. There is this thing called classifier guided diffusion and classifier free guidance. So everything comes with a cost. If you were to make it quicker and you are okay to pay the price of non-explainability, you can use classifier free guidance. If you were to make it more explainable, then one would use classifier guided diffusion. That is also more explainable and causal, but it will take a lot more time. Yeah, but there are
Excellent.
definitely ways to do that.
So I think it's a great lead for people to read more about classifier guided diffusion. Sorry, I'm rushing. The third question is from Nikhil Kamath. He says for cross-model application, if we have large data sets for both modalities, but no paired samples from the same subjects, right? We approach generative modeling.
See, these are the questions that are being asked are research areas by themselves. They're very, very relevant, right? Yeah. So, see, pairing is not needed today. So there are these multimodal LLMs that, as they are called, they are not LLMs. So what people do is they have a textual. See, what is done in this particular scenario is that you train different modalities differently, right? You don't have to pair them. You train generative models for different modalities separately, and then you have separate projectors that would project the semantics from one modality to the other modality. So this is the very broad way of how one would go about doing it. But as I said, it's an area by itself. I can teach an entire course on this, so how one would do it. But yeah, that's how one would go about solving that. See, I would like to mention, if you have more questions, feel free to write to me. I'll be happy to take your
Did we
questions
lose
back
it?
offline as well. Hello. Hello.
Yeah.
Can you hear me?
Yeah, Prathosh, we can hear you.
Okay. Yeah, sure. I don't know if you lost
I
me
think maybe
sometime.
I think there's one last question, maybe, I think from
Yeah.
Joanna. Yeah, Geetha, go
So
ahead.
what actually maybe what we can do, Shiva, is Prathosh, if you can answer the question on chat, we can move on to the next. Just in the interest of time, there's huge interest in what you presented, and thank you very much once again for the wonderful talk, and look forward to some kind of interaction from you and make you AIIMA researcher shortly, right? I know you don't work on infrared yet. So with that, and maybe people can express their reactions, which is nice, right? About what they feel about the talk. Please go ahead and give a big hand to Prathosh in the Zoom way. Okay. So with this, let's move to the session one. Sorry, I have to rush given the time constraint. So the session one, as I mentioned, will be chaired by Vaibhav. It will be on interpretable and feature-driven AI. And Vaibhav, as we introduced before, is a research scientist at Google DeepMind, and 15 years of experience in AI/ML algorithm design. Particularly, he's very passionate about applications in healthcare. He's developed several innovative methods for healthcare applications, particularly using AI/ML, and he's co-authored 85 plus publications in biomedical conferences and journals, and led different projects. At National University of Singapore, he was where he was an assistant professor, and at Xerox Research and Hewlett Packard, where I, of course, had the privilege of working with him. And he's been very much associated with startups as well, like Videocon and others, and his own startup in medical field. And so he does think more research and implementation, with a PhD in computer science from EPFL, Switzerland. So over to you, Vaibhav, to chair the session. If you want, I can leave the agenda here. I am handing over the mic to you.
Sure. Thank you so much, Dr. Geetha and Shiva. It's been a pleasure. I'm very happy to be part of this community. Today's session has 5 papers, as you can see, and they are very interesting, ranging from, there are various applications here, ranging from applications in pneumonia to breast cancer and sports related and so on. So yeah, let's get started without further ado. Just a quick reminder that each presentation will be of duration 10 minutes with 2 minutes for questions. Please feel free to send your questions on chat, and the speakers can then answer them on text. So let's get started. I'd like to invite the first speaker, who is Sotiris. The first paper is by Sotiris, Raptis, and others. Yeah.
Please share your screen. Yeah, we can see the slides. Please get started. Thank you.
We cannot hear you. You're not audible. Sotiris, can you check your mic, please?
Okay.
Yeah, I can hear you now. Great.
No, that was me.
Oh, that was you. Okay. We cannot hear you. Maybe let me message.
Oh, I think he's already started
Hmm.
presenting. Mhm. Do you have his number, phone number, Shiva? You can call him.
No, maybe we can move to next presentation. I will message him.
I cannot
Yeah.
message him directly. Can you message him directly? Shiva?
Yes, I messaged him. Yes.
Okay. So, okay, he's not sharing.
Good afternoon, and thank you for being here. I would like to ask whether my presentation is clear and visible to you so that I may begin.
Yes. Yeah, please begin. Yeah. It would be good if you could put it in
My
slideshow
name
mode,
is
so it's
Curtis
full
and I'm
screen.
from Greece. In this talk, I present a feasibility study for the early detection of radiation pneumonitis by fusing structural information from CT radiomics with functional signals derived from infrared thermography. The idea is straightforward. Functional changes in breathing and surface temperature can appear before radiological changes. So we bring those signals together in a transparent, clinically minded workflow. I will walk you through the motivation, the data, the fusion pipeline, the model, the results, and what they mean in practice. This slide motivates the problem. Radiation pneumonitis is a subacute inflammatory toxicity after thoracic radiotherapy. Symptoms can emerge before clear CT findings, leaving a short window where the clinician lacks decisive imaging cues. Here is the objective and the
Sorry to
contribution.
interrupt you.
Our goal is
This,
earlier recognition of pneumonitis risk by combining structural CT radiomics with functional infrared-derived surrogates. The contribution is a future-level fusion
excuse
pipeline
me.
with careful cross-validation, calibration, and explainability. We frame it as a feasibility study. The method is rigorous, but we avoid overstating generalizability until prospective
Should we move to the next presenter, Vaibhav?
Yeah, I was just going to say, Shiva, are you able to contact him?
No, he's not responding in chat. So, Tiris, can you hear us?
Yes, of course.
Okay. So,
Yeah, I think your slides are not moving. If you could put it on slideshow mode, make it full screen so we can see the slides and see how as you move it.
This slide motivates the problem. Radiation pneumonitis is a subacute inflammatory toxicity after thoracic radiotherapy. Symptoms can emerge before clear CT findings, leaving a short window where the clinician lacks decisive imaging cues. Here is the objective and the contribution. Our goal is earlier recognition of pneumonitis risk by combining structural CT radiomics with functional infrared-derived surrogates. The contribution is a future-level fusion pipeline with careful cross-validation, calibration, and explainability. We frame it as a feasibility study. The method is rigorous, but we avoid overstating generalizability until prospective paired data are collected. And this slide summarizes the data. We use a balanced CT cohort with known pneumonitis outcomes to extract IBSI-compliant radiomic features. Because paired CT and infrared data for the same patients are not yet available, we introduce infrared surrogates that reflect febrile or respiratory inflammation phenotypes. We pair labels conservatively and control for domain safety in later analysis. The aim is to capture functional signals that plausibly precede what CT alone can show. Here, we unpack the functional indicators we extract from infrared sources. The audience can focus on two families of signals: temperature-based asymmetry across the left and right thorax, and simple measures of breathing dynamics such as rate and cycle variability. These are physiologically interpretable proxies for inflammation and dysventilation that can change before structural alterations are visible on CT. We begin with CT DICOM scans labeled RP positive or negative. We extract IBSI radiomics, first order, shape, and textures. In parallel, we acquire infrared thermal data and compute functional features: left-right chest temperature asymmetry, breathing rate, and cycle variability within thoracic ROIs. Both streams merge at feature-level fusion. We train RF random forest with probability calibration and interpret contributions using SAP. So the bottom box is performance evaluation. Stratified CV stands for cross-validation with no leakage, reporting sensitivity, specificity, accuracy, AUC, calibration, and robustness. This is the fusion pipeline at a glance. On the left, CT radiomics provide about 100 structural descriptors. On the right, a compact set of infrared-derived functional features. In the center, we perform Z-score normalization, feature selection inside the training folds, and train a classifier with probability calibration. The key message is that all pre-processing is confined to the training partitions to avoid any leakage, and outputs are calibrated for practical risk satisfaction. Here on the left, you see an infrared thermography frame of the anterior chest. The color map highlights surface temperature. Warmer colors indicate higher skin temperature over the lungs. We quantify left-right temperature asymmetry here, which serves as a functional surrogate that can change before structural findings appear. On the right, this is an axial CT slice. The colored ROIs mark where we extract IBSI, compliant radiomic features, first-order statistics, and textures such as GLCM entropy. Together, IR captures early functional shifts, while CT captures structural texture, and we fuse both feature sets downstream. Now to the learning setup. We benchmarked several tabular classifiers and selected a random forest-based model for stability and compatibility with explainability tools. Evaluation used stratified cross-validation with selection and scaling nested inside its fold. We also include robustness checks, label permutation on the infrared side, and leave on the infrared dataset out tests, and we assess probability quality through calibration metrics because well-calibrated risk is more actionable in clinic. This ROC plot compares CT alone to CT plus infrared fusion. The x-axis is false positive rate, the y-axis is true positive rate. The dashed line is a chance. The blue fused curve lies above the orange CT-only curve across thresholds, indicating consistently better discrimination. AUC increases from about the high 70s with CT only to about the low 90s with fusion. In practice, we would choose a sensitivity first operating point, catching early RP cases while still keeping roughly 80/10 specificity. The takeaway, adding functional IR cues shifts the entire operating frontier upward. These are the headline results comparing CT alone with a fused CT plus infrared model. Red on the axis on the plots and then focus on the take-home. The fused model raises sensitivity substantially while also improving overall discrimination, roughly moving from the high 70s are under the curve for CT alone to the low 90s when we add the functional signals with accuracy and precision remaining strong. The practical implication is fewer missed early cases without a large penalty in false positives. Here we explain what drives the decisions. Feature importance and attribution analysis highlight left-right thermal asymmetry and respiratory variability as leading contributions to early positives, while CT texture-based features remain prominent in the more advanced or clearer cases. The mix is reassuring, complementary functional and structural signals rather than domination by a single modality. This is an explainability-focused visual that complements the previous slide of what drives decisions. If you see a bee-worm style plot, each dot is a patient. The horizontal position is a sub-contribution to the prediction, and the color encodes the feature value. Notice how higher left-right temperature asymmetry typically pushes the prediction toward pneumonitis, while very regular breathing tends to pull it down. CT texture measures such as GAN-CNN entropy also appear on the positive side for cases with subtle but diffuse parenchymal changes. If the figure instead shows partial dependence curves, read them left to right. Increasing asymmetry raises risk smoothly, whereas breathing variability has a threshold-like effect. The purpose of this slide is to make the functional structural complementarity tangible at the case level. We are transparent about limitations. The main one is the lack of paired CT and infrared recordings in the same pneumonitis patients, which introduces potential domain shift. The sample size is modest and the time points may be misaligned across sources. Our next steps are prospective paired acquisition at multiple time points, external validation, and more expressive hybrid models that still preserve interpretability. To conclude, the key result is that adding simple, physiologically grounded infrared features to CT radiomics moves detection earlier. We gain sensitivity and overall discrimination without a large cost in specificity, and the outputs are calibrated and explainable. We stress that our evaluation avoided leakage and included robustness checks, so the gains are unlikely to be artifacts. The immediate next step is a prospective paired CT infrared study with external validation and pre-registered operating points, along with decision curve analysis to quantify critical benefit. We are actively seeking clinical partners and sites for multi-center validation, of course under IRB and ethics approvals. I would like to thank our teams at the University of Thessaly and the International Hellenic University, our clinical collaborators, and the data providers who made this work possible. I am happy to take your questions now.
Yeah. Thank you for the very interesting study and very promising results for integrating IR. I think there are two questions on the chat. The first question from Shiva is, could you share the results of how infrared alone has performed?
Yes, I will.
Thank you for this excellent question. You are absolutely right that the use of infrared surrogates is the main limitation. That is why we focused heavily on controls against bias and leakage. First, all pre-processing steps Scaling, feature selection, and calibration are strictly nested inside each training fold. Second, the infrared surrogates have no deterministic link to the CT labels, and our robustness tests support that. When we permute the infrared features within class, the performance drops back to CT-only levels, showing that the gain is not caused by leakage or dataset bias. Looking ahead, the next step is a prospective paired CT infrared study where the same patients will be scanned with both modalities at multiple time points. We'll also pre-register a sensitivity first threshold and perform external validation and decision curve analysis to demonstrate true clinical benefit. So, in short, the current study is a rigorous feasibility step, and the prospective paired study is designed to confirm generalizability and real impact.
Thanks, Dr. There's another question from Dr. Geetha. What was the sample size and how many control points did you use to generate the ROC curve?
Thank you so much, everyone, for your attention. I wish the conference goes very well in its continuation, and thank you so much for the opportunity to present here. And so if you have any further questions, please don't hesitate to reach out on my email attached on this slide. Thank you so much.
I think there's some audio issues.
Thank you very much for another thoughtful question. Due to our limited time and in order to provide you with a well-supported and properly detailed answer, may I kindly ask you to send it to the email shown here. I will make sure to respond as soon as possible. Thank you, and I wish you a wonderful continuation of this very interesting conference.
Right. Thank you so much. Let us move on to our next presentation. Let's move on to our next presentation, which is on interpretable breast cancer risk stratification using statistical feature engineering on thermal images by Chandrima Hazra and others.
Yes, I'm available. Can I start?
Yes, please start. Yeah.
Hello everyone, my name is Chandrima Hazra from Department of Statistics and Data Science at Christ University, Bangalore. Today I'm excited to present my research titled Interpretable Breast Cancer Risk Stratification using Statistical Feature Engineering on Thermal Images. This work aims to solve a critical problem of trust in medical AI, and I would like to thank AIIMA conference for the opportunities to share it with you. As we know, breast cancer is a significant global health risk. The current standard for screening is the mammogram. However, it is not a perfect tool. It involves ionizing radiation and importantly can be less reliable for women with dense breast tissue, which can lead to false negative or positives. This brings us to a promising alternative, infrared thermography. It is completely safe, non-invasive, and uses zero radiation. It works by creating a heat map of the skin surface. The underlying theory is that cancerous activity with its high metabolic rate creates susceptible hotspot which a thermal camera can detect. When we looked at the existing research, we found two main approaches. On one hand, deep learning models like CNNs are being used and they achieved high accuracy, but they operate as black box. You get an answer, but you don't know how it was decided. On the other hand, traditional machine learning models are more transparent, but they often struggle with noisy, high-dimensional data and are less accurate. So these create what we identified as the research gap. For a tool to be adapted in a clinical settings, doctor need to trust it. The why behind the prediction is just as important as the prediction itself. Our contribution is to bridge this gap by using a rigorous statistical approach to build what we call a glass box model, one that is both high performing and easy to understand. This black box dilemma is the central problem our research tackles. A black box model might be 99% accurate, but if it can't explain why it's flagging a patient, a doctor will hesitate to base a critical health decision on that. So as you can see from the diagram, this leads to a lack of trust. So our solution is to build an inherently interpretable glass box model so that the final output is not just a prediction but also gives a clear explanation. This builds the trust and variability that the essential for clinical adoption. So how did we build these glass box? So our methodology was a clear 5-step process. First, feature engineering. We extracted 8 key features from the raw thermal images. The second is significant testing. We used the Mann-Whitney U-test to prove these features were statistically valid. Third is feature selection. We applied lasso regularization to filter out the noise and select only the 5 most predictive features. Fourth is data balancing. We used a technique called SMOT to correct a significant class imbalance in our training data. And finally, modeling. We trained and evaluated 2 models, logistic regression and random forest, to see which performed best. So diving into step 1, we extracted 2 types of statistical features, first order statistics and second order statistics. First order statistics describe the overall intensity of the image that include features like mean, standard deviation, skewness, and kurtosis. And the second order statistics are more advanced. These look at the texture of the heat map by analyzing the relationship between the pixels. Using a GLCL matrix, we extracted features like contrast and energy. Once we had our 8 features, we had to prove they were not just random noise. We used the Mann-Whitney U-test to compare the healthy and sick classes for each feature. As you can see from the box plot also, there are clear statistically significant differences in the distribution. For example, the mean temperature for the sick class is visibly higher than the healthy class. This step confirms that our features contain a real detectable signal. Having 8 key features was good, but we knew some of them more were likely to reductant or overlapping, what's called multicollinearity. To solve this multicollinearity, we use lasso regularization. You can think of lasso as an automatic filter. As we increase its strength, it forces the coefficient of reductant or noisy feature to shrink all the way to 0, effectively removing them. So the plot here shows that as the regularization strength increases, many features drop to 0, but a few survive. This process allowed us to find the winning team of the 5 most robust and predictive features as mean, standard deviation, kurtosis, contrast, and energy. The major challenge in medical data is class imbalance. Our training data had far more sick samples than the healthy ones. Our lazy model could just get sick every time and still get high accuracy, but to fix it, we use SMOT. SMOT doesn't duplicate the healthy samples, it creates new realistic synthetic samples. On the left, you can see the original imbalance data. On the right, after applying SMOT, you can see the new green synthetic points that have filled in the minority class. This crucial step ensures our model learns to identify both classes equally well. Now, for the result, we tested our 2 models on a completely unseen dataset. The logistic model, our baseline, achieved a high AUC of 0.96, but look at its recall for healthy patients, it is 0.13. This is critical failure. It means the model missed almost 90% of the healthy patient, mislabeling them as sick. So now if we look at the random forest model, it achieves 0.96% accuracy and a higher 0.98 AUC, and most importantly, a healthy recall of 0.88, and we can say that this is vastly superior, balanced and reliable model. Now, this confusion matrix shows the story even more clearly. On the left side, we can see logistic model was heavily biased. It misclassified 52 healthy patients as sick, and there are 52 false positive that would cause unnecessary stress and follow-up procedures. On the right, random forest model is a different story. It correctly identified 53 out of 60 healthy patients and 119 out of 126 patients. The performance is balanced and the error rate is incredibly low. But here is the most important takeaway. We didn't just get a high accuracy score. We know why, because we built a glass model. The random models can tell us exactly which feature it used to make its decision. And this chart shows mean temperature was the most important predictor, and this makes the perfect clinical sense. It was followed by texture features like energy and correlation. This is the interpretability we were aiming for. A doctor can look at this and trust the result because it based on a logical, understandable thermal properties. Now, in discussion, our works validates that the statistically driven glasswork approach is highly effective. We have shown that a small set of just 5 understandable features holds significant diagnosis power, and this transparency is the key to building clinical trust. For future work, we can see 3 clear paths: moving to a multi-class model to differentiate between healthy, benign, and malignant tumors; external validation on new dataset from different hospital and cameras; and multimodal fusion, combining our thermal data with other sources like mammogram and patient history. Now, to conclude my presentation, our research has successfully created a fully transparent and interpretable pipeline for breast cancer risk analysis by using rigorous statistical methods. Our random forest model achieved an outstanding 96% accuracy and 0.98 AUC on unseen test data using only 5 key features. And most importantly, this work offers a powerful and viable alternative to black box AI, blending high performance with this clarity and trust that medicine demands. Thank you all for your attention. I would like to acknowledge the DMR-IR dataset for making this work possible. I would like happy to answer any question you may have.
Yeah, thank you, Chandrima. There is a question on the chat. Why were only logistic regression and random forest models chosen?
I have used logistic as my baseline model, and I also tested the SVM model, but all other models I did was giving the same result as the random forest. So I only choose logistic and random forest for my research paper.
Thank you. Are there any other questions from the audience?
There's one more from Ninath before that, Vaibhav.
Oh, yes, sorry. Yeah, I missed that. Have you performed any pre-processing on raw thermal images, scaling or removing noise artifact before you did the feature engineering?
No, I didn't perform anything, any predetermined thing. I just take the mean, like the statistical first order statistics and second order statistics to extract our features, and then I perform the lasso smart to evaluate our model, and then I tested on the unseen data to validate our model.
I think there's a follow-up question. So does that mean that you used raw images?
Yes, it was raw images. The dataset was DMR-IR dataset. It is publicly available. I used that dataset directly.
Hmm. So again, following up, what about noise in the data and shape mismatch? How do you handle that?
I think in that DMR-IR dataset, it was not like that. Because I checked with other research papers also, whoever used that dataset, it was not that much pre-processing needed for that. It was fully noiseless, you can say, because the dataset, I didn't handle anything unusual there. And I checked with the other research paper, whoever used that model. It was, I think it's because of the dataset was like that from the beginning. So I didn't have to do any pre-processing like that.
Right. So you just mentioned previous papers. Can you give us an indication of how do previous models perform on the same data set?
The accuracy and AUC value is almost same, but they have used different approaches like deep learning models, which I already told,
I
CNN
see.
and that models they use. But I performed using like base level model like random forest and logistic. Though logistic didn't give much accuracy, but random forest really worked well in my dataset.
All right. If there are no further questions, then we can move forward. Thank you so much, Chandrika. All the best for taking this work forward.
Thank you, sir.
Yeah. The next paper is thermal asymmetry in football players following ankle injury, findings related to training load by Ahmed Bayrak and others. Request the speaker to
I'm here.
presentation.
I will present these papers.
Sure. Please go ahead.
Okay, I shared my presentation. There's any problem? Do you hear me?
I can see the slide and hear you, yes.
Thank you. Before I start, I want to thank you, the all community. I'm so excited and I feel glad in front of valuable community for this. And okay, I'm so excited to make this presentation to you. My name is Mahmut Çevik. I'm working on Atlet's Healthy Technology as AI team lead at AI Vision Tech. And today I will present our study on thermal asymmetry in football players with and without a history of lateral ankle sprain. Here's the outline of my talk. I will start with LAS, and LAS is a lateral ankle sprain. I will use this short name after that, and why it matters, then explain thermography and our hypothesis, followed by methodology results from day 1 and day 14, the K findings, and finally the discussions. Lateral ankle sprain is one of the most common sports injuries, responsible for about 40% of all cases. Most sprains occur through immersion, and around 73% involve the ATFL ligament. ATFL ligament, you showed these pages on slides. Globally, LAS affects 1.7 billion people with 2 million new cases each year in the US. Athletes miss about 15 days after LAS, but this is often not enough for full healing. This leads to 70% recurrence rate, and between 10 and 40% may develop chronic instability. Previous LAS is the strongest risk factor for a future sprain. Thermography measures infrared heat from the skin and reflects physiological changes. We focus on the site-to-site symmetrical site temperature difference called that delta T, which can indicate instability, inflammation, or abnormal loading. This makes thermography useful for detecting early subclinical risk in athletes. We included 5 regions of the lower extremity for analysis for study: ankle, patellar tendon, calf medialis, calf lateralis, and tibialis anterior. For each region, we calculate the absolute right-left difference. We also computed difference post and previous thermography analysis, thermography measure to evaluate the acute training effect. All analyses were done using our AI for Sports automated thermal analysis system. We calculate thermal images before and after training on day 1 and day 14 of the pre-season camp. We chose 2 days because of day 1 is the first day on the pre-season camp, and day 14 is the middle of the pre-season camp, and we use this calculate that acute day 1 is the first pre-season camp. We use the acute loading, acute effects. Middle of the camp, we calculate the loading effect for these players. This allowed us to compare both the immediate training response and the short-term adaptation. We evaluate delta T values separately for athletes with and without LAS history. The study included 27 players in the under 19 of one of the Turkish Super League teams, 10 with LAS history and 17 without. We have rules include the LAS history and the players. The rules is previous injury causing 3 or more 3 days time loss for this specific to this injury. That and this thermal images were taken for 5 lower limb regions on both days before and after training. This gave us controlled datasets compare how training load affects each group. We have an included rules for injury history group. I said that previous that on day 1, the LAS history group showed clear delta T increase at the ankle and patellar tendon. For ankle, plus 0.19 degrees Celsius, and for patellar, increased plus 0.21 degrees Celsius. The no history group showed decrease in both regions. No meaningful change appeared in calf or tibialis anterior on the first day, indicating that early response are mainly at joint and tendon level. By day 14, pattern changed. Delta T increased, shifted to the muscle level. Calf medialis and lateralis increased only in the LAS history group. For the LAS history group, plus 0.07 degrees Celsius and plus 0.06 degrees Celsius. You can check this points. The tibialis anterior showed a decrease in both groups, suggesting a different functional role. This shift from joint level to muscle level asymmetry is an important finding for us. Overall, athletes with LAS history showed stronger and earlier thermal reaction. Asymmetry starts at the ankle and patellar tendon, then extends to the calf muscles by day 14. This pattern suggests altered neuromuscular control and compensatory loading. The tibialis anterior behaved differently, consistent with increased tone and reduced elasticity described in previous studies are researched. Early joint level asymmetry reflects instability and altered mechanics caused by previous injury. Later calf asymmetry indicates compensatory adjustments over time. The tibialis anterior unique pattern may relate to specific stiffness characteristics often found in athletes with chronic ankle instability. Ankle-knee biomechanics also explain how ankle problems influence knee loading. Overall, thermography helps visualize these subclinical changes and may support in the visualized load management. And thank you for listening. I will happy to answer your question. And I have appendix slides. You can check all muscles or joint ligament changed day by day for this. Thank you.
Thank you very much for this very interesting study. Are there any questions from the audience?
I checked the chats. I don't show
Let
any.
me ask one while there are questions coming from the audience. So this is a very interesting thermographic biomarker.
Yes.
Would you know if the same kind of biomarker or similar biomarkers are there using other modalities for the same condition, which is lateral ankle sprain?
These studies, we focused just thermography for that, but we will use other biomechanicals changed, calculated for this, and I let you GPS loading, you know, maybe I check my notes and I write on the text.
Sure, sure.
I now remember those biomechanicals changed.
Sure. I was just curious what other biomarkers are there apart from the thermographic biomarkers, and it looks like thermographic biomarkers are very easy to measure and yeah.
You know the all players happened injury in the preseason. It's we calculated measure that loading objectively loading the changed. Our suggestion maybe we cut the before happened the injury, we calculated and we measured this difference showed and we cut this injury before happened. Thank you. I don't want that over my time.
No, this is good. I guess there are no further questions. So yeah, let's thank the speaker again and let's move on to the next presentation.
Well, I have a question, Vishal here.
Oh, sorry. Yes, please, Vishal, go ahead.
Yeah, I wanted to ask who is the end consumer for the project just we discussed? Is it like the goal is to assist doctors or is it for the sports franchise, medical staff? Like, how do they utilize this, what has been built, or it is just as of now into study or a research?
Uh, Muhammad Chevik, I think this question is for you. I'm not sure if he's
Sorry, I don't hear the question. I didn't hear the question.
I think the question from Vishal is who will benefit from this study? Who is the end user?
It's the benefits players, athletes, and staff, club staff use this thermography and measurement, difference measurement, calculate this thermographic image and check this changed difference and use the inside information that and compare our other biomechanical or athlete loading measurement findings and creates these players may injured after this season or after this match. Players and club staff who
So, ma'am,
benefits.
Vishal here again. So is it like form of a prediction also, like you said, right? We are looking for thermal signatures, and if let's say somebody had an intense match, we can look at the thermal markers and say that okay, this person or this player might get injured if they play like another match, if they need rest or not. Is that my understanding correct?
Yes. We have a cutoff degrees that changed, and we classified this risk for the players over the 1 degrees the difference, and these players may injure it.
Yeah, sorry to
Got
interrupt
it.
this very interesting discussion. May I request to take the discussion forward on the chat in the interest of time
Yes.
to move ahead to the next presentation. So the next presentation is by Nitya Kalyani Krishnan and Snake Khaleta on a non-invasive diagnostic approach to orofacial pain using infrared thermography and machine learning.
Good evening, everyone. Is my screen visible?
Yes, it's visible and you're audible. Please go ahead.
Good evening, everyone. This is Dr. Nitya Kalyani Krishnan from the Department of Biomedical Engineering at SRM IST, Katan Kulatur campus. So today I'll be presenting my research work on the title, A Non-Invasive Diagnostic Approach to Orofacial Pain Using Infrared Thermography and Machine Learning. So I'm happy to share the clinical findings and the details and also the methods we adopted in our research work. So I'll give a brief introduction about what is orofacial pain. It is the pain that is felt in the face, mouth, and jaws or associated structures. So it encompasses the wide range of conditions that might be a dental issue, musculoskeletal, temporomandibular disorder, that is TMJ disorder, neuropathic or idiopathic in condition. So it is one of the chronic pain disorder that usually been encountered in clinical practice. This can affect a person's quality of life, like like eating. They'll be having issues with eating, speaking, or even expressing their emotions. So common causes include the dental infections, TMJ disorders, then myofascial pain, neuralgias, and referred pain from sinus or ear issues. So the motivation behind the research work is so actually orofacial pain is a complex and complicated condition because we'll be having so many overlapping symptoms for this particular disorder. So we have conventional imaging methods such as MRI, which are effective, but they're very expensive and time consuming and very uncomfortable for the patients. So infrared thermography offers a non-invasive, non-contact, radiation-free and cost-effective approach for accessing the physiological changes such as inflammation and improved blood flow. So we have integrated the clinical image, the imaging modality such as thermography with the computational intelligence technique such as machine learning to enhance the early detection of this particular condition, objective assessment and personalized management of this particular orofacial condition. So the problem statement, though, as I mentioned before, it is very challenging due to the overlapping symptoms and lack of objective assessment methods. So the existing diagnostic techniques do not provide real-time physiological information and relies heavily on subjective reporting. This can be used so that infrared thermography can be used as a complementary tool for assessing individuals with this particular condition. So there is a need of an integrated diagnostic framework that combines both thermal imaging and computational analysis to identify and classify different orofacial conditions. So we have developed such a system which enables non-invasive, accurate and accessible pain evaluation, improving clinical decision making and patient outcomes. So the aim and objectives, basically what is our aim is to develop an automated diagnostic framework which is going to integrate two things like infrared thermography and machine learning. So it is a multimodal framework, and objectives first is to acquire the thermal images, pre-process it and extract the features, and to apply principal component analysis method for reducing the dimensionality. And the third one is to evaluate the whatever the machine learning classifiers we have used to classify. We have just used and evaluated which performs the best. So literature review. In previous studies, there were so many authors who have done research based on orofacial pain condition. Here in the first paper, the AI has achieved a superior sensitivity and specificity versus clinicians, and it is effective for pain quantification. But it has few limitations. That it is limited to post-operative pain, and performance may vary for chronic or multifactorial pain conditions. And in the second paper, exactly they have used multimodal diagnostic approaches in OFE management, but it lacks experimental validation on this particular article. And Pray et al. Here they've attained 89 to 92% accuracy and validated portable IRT for wound monitoring. That is for other pathological conditions also. I have just done the literature. Because in this particular pathology, the articles are very quite limited. And in the fourth paper, Shuang et al., it has delivered they have delivered high accuracy and real-time inference for clinical use, but they focused on elderly subjects, and they need a proper demographic validation and multimodal integration. And in the last study, like research study, they have emphasized complementary roles of deep learning methods and interpretable methods where they have lacked human pain data set validation. So next, this is an overview of the study. The participants were selected, proper consent were obtained from the subjects after getting ethical approval from SRM Medical College, and the participant selection was after participant selection, the control subjects where the study group was n is equal to 40, the healthy group, and study subjects were n is equal to 40. It was a balanced data set was followed, and the facial thermograms were obtained, and high temperature region extraction was done, and finally the features were selected, and finally the classification is done using the machine learning models. So thermal imaging, usually thermal imaging will have a particular protocol for collecting the images. So thermal imaging data were collected according to the protocol in order to evaluate the feasibility of using thermal imaging and machine learning for detecting orofacial pain. So a total of 80 participants were recruited, and 40 patients with clinically diagnosed orofacial and 40 healthy controls. The age was between 25 to 50 years, and they were recruited from SRM Kattankulathur Dental College and Hospital, and proper ethical clearance were obtained. So infrared thermograms were captured using a specific camera like FLIR A305 SC thermal camera, and there is a proper protocol which was followed. Like, camera was mounted 1 meter away from the patient under controlled environmental conditions, and each subject will undergo a acclimatization process that they will adapt to the environment, like within a period of 10 to 15 minutes before imaging. And thermal images were recorded in different profiles, like frontal, left and right profiles were captured, while participants maintained neutral facial posture, and a black background was used to minimize the reflections and thermal noise, ensuring the uniform and high quality data acquisition for subsequent analysis. So these are the two sample thermograms. This visual representation is for the A, like figure 3A. If you could see, the facial thermogram of a normal subject has been presented, and here in the second one, subject with orofacial pain has been represented, emphasizing the region of interest, which indicates the abnormal temperature distribution on the face. And data loading and preparation. The data was divided into two folders, like normal and abnormal, and it was pre-processed. Like, basic pre-processing was done. It was not done on raw images. Like, the noise was removed using median filter. Then it was performed using OpenCV library to ensure consistency and reliability for machine learning analysis. So these images were loaded, and they were in order to maintain a uniformity in all the images, it was resized to 120 cross 128 cross 128 pixels. So ensuring compatibility with the neural network architectures requiring fixed input dimensions. And then what was done was it was then sent to the feature extraction process. Here PCA was first, it was like 3 different features were segmented, like textural features, statistical features were done, and the textural features, here we have used LBP technique, which is a visual technique, like technique which was applied onto the image to extract the texture features, emphasizing the subtle local variations in temperature. For each and every image, a 20-bin histogram of LBP values was generated to capture the texture distribution, and statistical features such as mean, standard deviation, median, maximum, and minimum pixel intensities were first computed before this textual feature computation. And to include spatial information, each image was divided into 4 quadrants, and the mean pixel intensity of each region was calculated. And as I told, it was resized, and it was flattened. The resized images were also flattened into a single vector to preserve detailed pixel level information. In order to preserve the information, we are doing this. And finally, all the features were combined into a single feature matrix, serving as the input for subsequent machine learning analysis. And we have standardization and dimensionality reduction. To enhance the performance of the ML models, the extracted features were subjected to standardization and dimensionality reduction. So basically, we have used subsequent functions for doing that. And following this standardization, we have implemented PCA was applied to reduce the dimensionality of the dataset while retaining the most important information in the features, and it captures the highest variance within the data, and the feature vectors were transformed along these new axes. So the number of components was chosen such as 95% of the original data variance was preserved. This approach not only simplified the computation but also minimized the redundancy and improves noise, ultimately improving the robustness and efficiency of the learning algorithms. And model selection, yes, the models were selected according to the user. What are the highlights of each and every model was analyzed, and few models were selected. So a diverse set of machine learning models were applied to classify thermal images and evaluate the performance. So first we have used the decision tree classifier was chosen for its interpretability and capacity to capture the nonlinear feature interactions. So it is mostly suitable for clinical decision making applications, and to enhance generalization and reduce overfitting, we are going for random forest, which is an example of all the decision trees. By averaging the predictions from several trees, this method improves both predictive accuracy and model stability. And the XGBoost algorithm was also implemented due to its computational efficiency, robust regularization mechanisms, and proven success in handling structured tabular data. So this particular algorithm constructs a trees sequentially, with each new tree correcting the errors of the previous ones. So it achieves stronger predictive performance while minimizing the overfitting issues. So additionally, the naive-Bayes classifier was employed as a probabilistic baseline model because of its simplicity, speed, and effectiveness on smaller datasets. And for the Gaussian naive-Bayes, it assumes that the features follow a Gaussian distribution, offering rapid and efficient processing for high-dimensional data. So the integration of all these models gave us a good performance, but when compared to all the models, decision tree was performing the best. So the performance of the machine learning models was evaluated using a stratified 5-fold cross-validation approach to ensure reliability and minimize the class imbalance. In this method, the data set was divided into 5 equal subsets while maintaining the original class distribution, with 4 folds used for training and 1 for testing in each iteration. So this ensured that every sample was used once as a test case, and the average performance across all folds will provide an objective assessment of the model accuracy. So there are so many performance measures that can be used, like specificity, sensitivity, ROC curve, and so everything was evaluated. Together, these measures ensured a robust, unbiased, and clinically meaningful evaluation of the diagnostic capability of each ML model. So these are the performance outcomes. We have just summarized here, like among all the models, decision tree has acquired the highest accuracy, and this has outperformed the other traditional models, so achieving the highest accuracy and a perfect recall value, indicating that all true orofacial pain cases were correctly detected. So it's high precision. It has a high precision. It can give high precision characteristics. So it further reflects minimal false positives, reducing the unnecessary follow-ups, and it avoids misclassifications. The superior reference code highlights a model's strong balance between the precision and the sensitivity. And although random forest and XGBoost achieve near perfect ROC, AUC values, this shows showing excellent class separability. They exhibited slightly lower accuracy, suggesting minor misclassification. So in contrast, naive-Bayes showed acceptable recall and AUC, but lower precision accuracy implies a higher false positive rate. Here we could see the visual representation of the combined ROC curves for the utilized ML classifiers. And this is the PCA projection of the final features graph. So here the normal cases are highlighted in blue color, which are tightly clustered, indicating low intra-class variability, while the abnormal classes, which are depicted in orange color, are more dispersed, spread, suggesting greater heterogeneity. So this separation confirms that the PCA reduced features retain strong discriminative capability. So it is capable of managing nonlinear boundaries in all the models, and this shows reduced performance due to its assumption of feature independence. Overall, the PCA separated clusters aligns with the interpretable decision boundaries for orofacial detection, pain detection. The summary of the study is here, like the objective of the study, dataset, features extracted, the dimensionality reduction, we are using PCA, the models utilized, best performance, like other best performance, and limitations, clinical relevance, and future work. Like future work is, we have a very limited number of data set, so we would like to expand the data set for further research work and perform external validation, improve generalizability, and test real-time clinical applicability. So this study demonstrates the clinical potential and feasibility of integrating two different modalities, like infrared thermal imaging with the artificial intelligence technique, machine learning for the non-invasive diagnosis of orofacial pain. So, as discussed earlier, we have just compared with the existing machine learning models, and we have selected the best classifier for orofacial detection, pain detection. I would like to acknowledge Dr. Snehalata for giving me this opportunity to represent the research team. Thank you.
Thank you very much. There's a question on the chat. Any ablation studies done on using only image features or statistical features?
So, one second. Yes, sir. Ablation studies were done. Basically, I used 12 to 15 machine learning classifiers, like 15 classifiers, and initially I've just removed 3. And proper ablation studies were done, and these machine learning classifiers were selected.
Right. So since we are running short on time, may I request you to answer other questions on the chat directly? And please ask questions directly on the chat. And we can move forward to the last talk, which is on defining normative interregional patterns in infrared thermography by Victor Lewis.
Yes, it's my
Yes,
it's my turn. I can share the screen.
Yes,
you can see it.
Go ahead.
Yeah, perfect. Okay, thank you. Thanks to organization for the opportunity to present our work beyond symmetry. Let me put yes. Okay. Beyond symmetry, defining normative interregional patterns in infrared thermography from the Thermohuman software database. So basically, our approach is that thermographic evaluation has been limited to isolating regions of interest, framing interpretation through a reducing lens. So when you choose only one region, you are not focusing on every part of the body. What is the state of the art? The body has a stable symmetry between contralateral regions of the body. So in healthy athletes, general thermal asymmetry is 0.004%. So the body is so symmetrically. But what happens when you didn't compare one region with another? So, for example, compare knee from bottom on the feet or knee from the upper body. This is our approach. So the problem of evaluating a region offers you only one piece of the puzzle. Previous studies show that in the face of complex injury, like ACL rupture, the body chooses compensatory strategies where thermography shows changes. For example, in this case, we have a ACL torn, and obviously the knee that presents an asymmetry is the right knee, that is the injured, but you can see another regions working to a compensatory strategies trying to reduce the load in this knee. So if you only assess the knee, you are missing one piece of the puzzle. There are previous approaches. This is not a novel idea. So yeah, in Uematsu in the first studies, he proposed a skin temperature gradient from the head to the hip and foot. But the thing is, we can do now with a lot of information, a lot of the, data from the database, and the aim of the study was to generate a thermal gradient scale to improve the understanding of the relationship between body regions, based on intra and interregional thermal relationships. The method was we analyzed all the thermographic images available in the Thermohuman database as May 6 of 2025. The number of protocols was above 150,000 images. So you have there we analyze from male and from female, and in the anterior superior part, the anterior inferior part, posterior superior part, and posterior inferior part for every sex. The segmentation analysis was this. We don't analyze the trunk, the interior part of the body, and also we don't analyze the glutes and the lateral part of the dorsal, because we don't pretend to only analyze the internal part of the body. So we pretend to analyze what happened in the extremities, lower and upper extremities. The statistical analysis was for each ROI, the mean and the standard deviation were calculated. A gradient model was generated to visualize the independent relationship between the regions of interest that share a protocol configuring 5 protocols for the region of interest. The result shows that we have 2 different mean data and also standard deviation from women and men. And we have, interestingly, the neck has a almost unvariable difference in both sexes. So for us, maybe neck is the ROI that could represent a reference region between both sexes. Also, the analysis about the standard deviation across all the ROIs was relatively homogeneous between sexes. So this indicates a reasonable stability of the measurements. For the gradient, we saw that there is a progressive decrease in the temperature from the most proximal part of the body to the most distal regions, as Uematsu found in the previous work. The most abrupt changes occur between the temperature of the forearm and the wrist. So the most distal regions decrease more the temperature than from the most proximal regions, both in the anterior and posterior protocol, with a decrease of 1.4 degrees and 1.6 degrees respectively, and in men 1.7 and 1.8 respectively. From the leg region to the ankle region, both in the anterior part and the posterior part, there is also decrease in the feet. Another notable decrease is that of the height relative to the knee. So when you pass over the articular part of the body, wrist, knee, what is the joints, you have a decrease on the temperature, because the joints are not they don't supply the blood flow as the muscles. Interestingly, in both men and women, the region from the neck to the trapezius experience an increase rather than a decrease in the temperature. So there is the only part of the body that increase the temperature from the proximal to the distal. In another word, this is the part. This is the region from the trapezius to the neck. Trapezius is hotter than the neck. This is the gradient that we create. It's a framework for the practitioner to work, because when you make a thermal image and you can compare with this framework to know if your assessment is more related to colder areas or to the hotter areas. So we create two different approach, one for the men, another for the women, because we understand that men and women are different, as we see in the study and also in the scientific literature. And in the discussion, we saw that the changes produced in the thermal gradient that represent a decrease in the temperature from the most proximal to the most distal could be explained by the fact that the body tries to preserve the vital organs that are located in the center of the body. So the body is trying to protect the center of the body, and the distal regions for the brain and for the body is less important than the thing that could happen in the middle. For this reason, we don't take the chest and the back for the analysis. Also, the results obtained from the database align closely with previous findings in the field of thermography, especially studies such as that of Neves et al. Have highlighted the influence of gender on body temperature distribution. So we need to make two different approach from women and from men to understand what happened in the temperature of the body. This is the actual transfer to the practice. We create a gradient model. We have a framework to compare what happened in the body when you make a thermal analysis. So, for example, in the case that I put in the first slide of the presentation, you have this kind of comparison. You can see that the knee in the right is hotter than the other knee, but the other regions like shin bone, ankle feet, and also quadriceps are in the other way. So you can understand that there is some points that are compensating and also some points that are no having a behavior like a normal behavior. So by establishing reference proportion under the standardized condition, the analysis enables direct comparisons across individuals and groups, allowing thermal deviation to be contextualized within a reproducible framework. For the conclusions, for instance, when performing an assessment and obtaining a thermographic measurement within a ROI, the value can be compared against the normative reference range provided by the gradient graph. While absolute temperatures might vary due to the technical and other contextual factors, including population characteristics and imaging conditions, the internal distribution patterns remain stable. So, stratifying this gradient by sex underscores the relevance of biological difference in thermal distribution, offering further precision in interpretation. Thank you very much for your attention, and I stay here for any question.
Thank you very much. We'll probably have time for just one question. I think there's a question on the chat from Shiva on the number of participants in the study. How many participants were there?
The problem is that we don't have the participant itself because we take the image, not the participant. Maybe we have only one picture for the upper body for one person, but it counts in the image database. I try to explain that, for example, in our protocol, you can take one picture only of the upper body, and it's not I don't know the word, like obligatory, compulsory to do every protocols. So we put like a very big pool of image, and we don't take the number of participants. So we take the number of pictures.
Yeah, so would it be possible for like the same participant, would it be possible to have multiple pictures from the same participant?
Yes.
Okay. Yeah.
But
I think
in different moments, so maybe you have different patterns in different moments.
okay. I think there's also a question about registration, about image registration issues.
No, we take the database like an anonymized database, so we don't have like a proper consent of the, because we only take the data of the temperature.
Mm-hmm. Okay, very quickly, I think
about the position of the image itself, like the foot can be, or the body can. I asked the same question for the previous speaker. On different days, you can keep the feet differently, body differently, right? So that image position changes.
No, the position about the assessment is always the same.
Not really.
Maybe we can discuss this offline since we are running 20 minutes late. There are a couple of more questions on the chat. Can I request the speaker to answer them directly on the chat? And with that, we conclude this session. Thank you very much to all the speakers for very interesting talks. And we can now move forward to the subsequent sessions.
Yeah, thank you very much, Vaibhav, for patiently listening and giving feedback and ensuring mostly sticking to the time. It's always a challenge, but yes, we have good news is we have some buffer. So, what we're going to do is we'll take a very short break. Just for any break and things like that. If you want to get some coffee, please do. So please come back in about 5 minutes. In India, it is 7:05, and maybe just add 5 minutes to whatever time zone you are. You to use the Zoom chat to connect and engage. Post that break, we're going to have Shiva chair the session 2, and the rest of the workshop will be run by him. So please come back soon, and Shiva will take over.
Yeah.
Thank you.
Thank you.
Yeah. Hi, everyone. Welcome back. I am Sivateja Kakleti, one of the co-chair and organizer of AIIMA. We will now move on to session 3, which is focused on open source resources for infrared thermal imaging. As we all know, open source tools and datasets are playing a crucial role in accelerating research, fostering innovation, and making medical imaging more accessible to the global community. Since thermal imaging is still an emerging research area, we have only few open source datasets that are publicly available. To encourage more submissions and strengthen this ecosystem, this year we are hosting this dedicated session on discussing the latest tools, datasets, and community efforts in open source resources for infrared thermal imaging. This session has 2 talks. The first one is presented by Flavia Pastura with the title Presenting a Dataset for 3D Breast Surface Reconstruction using Thermal Imaging.
Hello, everybody. Can I share my
Yes,
presentation?
you can share.
Okay. Are you seeing that?
Yes, we can see the screen. Can you keep the presentation mode?
Okay. It's okay?
Yes, that's great.
Okay. Hello, everybody. Good morning from Brazil. I will present. My name is Fábio Pastura. I work at the National Institute of Technology, and I will present the work presenting a data set for 3D breast surface representation using thermography. This work presents a data set acquired with the object of verifying the possibility of using thermography for the reconstruction of the external diameter of the breast. The main goal is the presentation of a new data set with breast surface with breast surface formation analysis of 31 studies. An additional object is to show the suitability of infrared image for the development of realistic models of breast shape. I will present the use of thermography image as a base for generating the 3D shape of the examined person to enhance the understanding and interpretation of this examination. Besides examining the thermography for image shape definition, this work also uses it for breast reconstruction, virtually or physically, by a 3D printer. The challenges are the use of more than one infrared acquisition in different angles for shape reconstruction, the greater heterogeneity of the breast appearance among the human beings, and the integration and transformation of any 2D infrared image in a 3D examination and applications of infrared image for breast volume evaluation. In the image capture environment, infrared images were captured at 5 and 23 angles, while volunteers remained in the thermal equilibrium with the environment, like it is shown in the image in the left. Also, 3D scanning of breasts and armpits from the right side to the left side of the body of the volunteers were captured. This was done to allow comparisons between reconstructions using the infrared and the scanned shapes. Also, 4 volunteers had their trunk and breast captured in great detail at 23 angles. One of the volunteers also had the external shape of her breast reproduced in a physical model. In the image capture environment, the camera was fixed on a rotating equipment that is shown in the figure at the left, and the volunteer was surrounded by a PVX curtains to avoid thermal reflections. On the right, we can see the polygonal mesh that were extracted from the scanned scene. The environment scene was reconstructed on Blender software, generate mesh at the same angles of the thermal captures. Here we can see the composition of dataset tables that show medical history, physical and social data, metrics that show temperature at each point in CVS files, image that show temperature in radiometric JPG files, and image that show the polygonal mesh in TLI files. The reconstructed models from scanning on the left and photogrammetry on the right are dimensionless, so they need to be rescaled. This was done based on the dimension of one of the sides of the insulating square that was fixed on the body of the volunteers. This is shown by the blue arrows. The horizontal white line on the polygonal mesh model at the left was measured, and then the same white line on the photogrammetry model was measured. The results were divided, finding a scale factor between them. This scale factor was applied to the models. Being correctly scaled, the models were aligned and a depth map was constructed. The scaled colors on the right shows the maximum values in y-axis. The process for 3D printing the breast involved first the segmentation of the torso and the breast regions. So then populating the breast region that is in the below in this figure at the left. Then this breast region that is the were populated. And the breast region were populating, and this is to form the adipose tissue area, with points that served to construct a Voronoi type structure. This is shown in the right figure. This Voronoi structure, let's return one. This Voronoi structure was then smoothed, that shown in this programming, and each cell was added through a union operation. The breast ducts on the left image were constructed in 4 steps. First, 2 circles with the size of the nipple were defined on the breast surface. Then, these circles were populated with points on same locations. Then lines were defined to connect these points, and finally, these lines defined the internal elements with variable radii. The breast lobes that are on the right side of the frame were similarly constructed by drawing surface with varying diameter sections that start on the same central region, that is the sphere located in the center. Then these surfaces were populated with points to give them a granular texture aspect. Concluding, in this work, we presented a set of breast scans from 30 volunteers, including Thermography and 3D image, the polygon mesh, as well as data that can be used for a wide range of researchers that may be useful to the community interested in studying this region of the body. We think that 3D thermography contributes to functional diagnostics, while 3D printing contributes to physical reconstruction. We think that together these technologies can form an integrated system that favors surgical planning, pathology screening, outcome assessment, and medical education, promote a more precise and personalized approach to humans healthcare. That's it. Thank you very much. And I'll be happy to answer any questions that may appear.
Thank you, Flavia, for the wonderful presentation. Maybe I'll ask the first question. So the 3D imaging is done only for the frontal view, or is it done on the lateral views as well to get the full breast reconstruction?
Only from the front and lateral views.
Okay, both front and lateral are.
Yeah.
Okay, then how is the registration done for frontal and lateral?
Sorry, I didn't understand.
Because you would be capturing two sets of images, right? You'll be getting an image if you're using a Kinect or any kind of depth map. You'd be getting the frontal depth maps and the lateral depth maps, right? So what are the techniques used for registering these two images to form the complete 3D surface?
Sorry, Siva, I thought I wrongly answered you. That math was just in the front side of the trunk,
okay,
not from the lateral. So what we have done is just to pick points in the mesh, and in the thermal, after they were scaled, both models were scaled, we picked points in one model to the other model, and manually first, and then the software that you used, that was Geomagic, did it automatically.
Okay.
And so we could see the ray G, the eye coordinates between both models.
Okay, that's good. So there's one question from the audience. Is the dataset publicly available for everyone?
Yes, they are.
Okay, I think Prof.
Dr. Aura Concept just put that on the chat.
Okay, that's good. I think everyone should use this data set for their research and come up with more papers in the next year, AIIMA. Thank you, Flavia, for the wonderful presentation.
Thank you very much.
Yeah, if there are any questions, please message, and Flavia would answer in chat itself. Yeah. Thank you once again.
Thank you very much. Bye-bye.
We now move on to the next presentation from Bharat Govindaraju from Nirama Health Analytics with a paper title Med-Thermal DICOM, an open source DICOM-compliant framework for medical thermal imaging, enabling clinical integration and research reproducibility.
Is my screen visible?
Bharat, the presentation is not visible. We can see your screen, that's it.
I'm sorry.
Maybe you can share the full screen.
Yeah. Oh, is it visible now?
Yes.
Hi, everyone. I'm Bharat. Today I'll be presenting our work on Med-Thermal DICOM, an open source DICOM-compliant framework for medical thermal imaging, enabling clinical integration and research reproducibility. So thermal imaging, as we know, is where we use thermal camera that captures the infrared radiation and converts to temperature map. And it has certain advantages, being radiation-free and non-invasive way to capture the physiological conditions to surface temperature distribution. So initially, thermal imaging was really explored in the 1960s for oncology, and the later progress was stalled due to some technical and lack of acquisition standards. Recent advances in thermal imaging hardware and AI algorithms have meant that we can better quantify thermal asymmetries and vascular patterns, and this has reignited the research interest. And the clinical application, so thermal imagings have a wide array of clinical applications across medicine, like in oncology, the AI-assisted breast cancer detection have sensitivities approaching the conventional imaging modalities in predicting diabetic foot ulcers, in wound healing, fever screening, pain management, and so on. So thermal imaging also has a lot of promise, but what is the current gap or the barrier to the widespread clinical adoption? So the current format in thermal imaging is the JPEG or in the PNG format, which lack the patient and which lacks the capture of patient information and also the device acquisition parameters, such as in thermal imaging, the important ones could be like emissivity, temperature calibration, the distance from camera, and so on, and patient-related information like the patient demographics, age, gender, and etc. So lack of this data means this makes studies non-repeatable, non-reproducible, and it limits traceability. And also crucially, these image formats are difficult to integrate with PACS. So PACS is the Picture Archiving and Communication System, which is a medical imaging system which is used to store data, retrieve it, and share it. And so lack of integration with PACS is one of the major bottlenecks. So the thermal imaging cannot be along the same side as the CT, X-ray, or MRI, which prevents multimodal viewing and analysis. It hinders the clinical workflow and also hinders the longitudinal tracking. That's tracking patients' health over time. So having seen these problems, so we have a global medical image standard called DICOM since the 1980s. And now DICOM has been supporting many of the conventional modalities that we know now, like MRI, CT, ultrasound, X-ray, and so on. So the DICOM standard has provisions to store the patient metadata and has enough scope to also add the acquisition data, and it enables secure storage, retrieval, and most importantly also we can is integrated with the PAC systems. So having seen the promise of thermal imaging, the gaps, and the DICOM standard, which is another imaging modalities, now we present the MedThermal DICOM, which is the open source framework for thermal DICOM generation. And we have built this with certain guiding principles. One is the compatibility. So it has to seamlessly integrate with the existing PACS and the clinical workflow systems. And then it should have provisions to store some critical parameters such as the patient information, demographics, and also be able to store thermally relevant data such as emissivity and distance of camera and so on, which we'll go into bit detail in the next slides. And also we also provide a feature to see the temperature values in the DICOM viewer that are taken from the thermal imaging. And we also support annotations of the region of interest, which could be like a segmentation mask of the lesions. And lastly, so how do you access this framework? So you can access it from a programmatic way, so that you can readily integrate it into your Python workflow, and or else you can also quickly generate DICOM from the thermal images using the graphical user interface. So our package is already up on the web package, so please feel free to download it and run your experiments. And you can also directly clone it from the Git repo, and you can also install it from the source. So on the framework architecture briefly, so how we build this open source framework is there are 4 layers to it. The foundation layer has the PyDICOM and the NumPy, the standard Python libraries. which enable us for the easy array manipulation thing. And then the second layer is the DICOM standards for ensuring compliance and validation. And the third is our core framework layer, where we encode the radiometric pixel data, we apply temperature transformation, and then where we also can apply the overlay layer and this integrate. And then the last layer is the application layer, which is the user-facing layer. So where we have this graphical user interface to quickly generate the DICOM, and those who want more technical and more control over how they generate DICOM, we also have a Python framework API for this. So to ensure interoperability while preserving the acquisition context, so we have two-stage metadata strategy. So in the first stage, we have the standard DICOM modules like patient name, the birth date, the study series information, the body part exam and anatomic region codes, where we also populate the SONMED CD codes and so on. And then the second stage is where we introduce a custom thermal specific private DICOM tags. These are introduced on the group 0019 within the DICOM vocabulary. So some of the parameters that we are talking about here, like emissivity, distance, thermal sensitivity, the spectral range, this is not part of the standard DICOM vocabulary, so we want to introduce it. So this private tags actually take care of those parameters. So another challenge of converting thermal to DICOM is we lose some temperature information, because in the DICOM the values are stored as unsigned integer format, whereas temperature values are in the float format. However, we use the standard DICOM tags of rescale slope and the rescale intercept to convert the values back to the original temperature values. So as we can see in this picture, so this is the DICOM that we generated from our framework, and we are seeing this in the region DICOM viewer. So this triangle region has this temperature called this temperature of 26.96, and when we hover over it, the DICOM viewer also shows the same temperature, which is just highlighted here. And we also have a use case where we want to add some overlays to our DICOMs, like it could be like a lesion marking or organ segmentation mask and so on. So for this, our framework also enables you to pass a binary mask of the region of interest, and the framework will add it as an overlay layer. So this overlay layer will not disturb the underlying pixel values. So the core pixel values are untouched. And they're also very easy to use from the library. It's just a single function call. And we also have the graphical user interface section, where you can quickly point to one of your thermal data, and the tool generates the DICOM. So this is the short demo of the same. So you browse the file, select your input, select where you want to store it, enter some details like patient name, age, patient ID, or setting organization UID is optional. If you have your own organization UID, you can set it, or else it will use a default one. Then you can just set the body part examine, set the view position laterality, and then say create DICOM, and you have a DICOM ready. And this is how it looks in the region DICOM viewer. So having had this DICOM generated from thermal images, so now there could be different use cases, like maybe if you're a researcher and you want to kind of reproduce a work, validate it, and or if you are a company or a medical professional and you want to integrate the DICOMs into packs, so that is possible with the DICOMs that are generated from our framework. You can readily integrate with packs, and that work with all these packs commands like cstore, cfind, cmove. And with this, we can ensure that even thermal imaging, the gap that was existing in thermal imaging and the medical imaging ecosystem, that can be bridged. So in conclusion, the MedThermal DICOM is the first fully open source DICOM-compliant framework for generating DICOMs from thermal images. With this way of format, and it shows reproducibility. It has quantitative fidelity when we're converting between float and int in the temperature, as I told earlier, in metadata preservations, and it overcomes the limitation of the current imaging standards of JPEG PNG. And with this, we can also seamlessly integrate into the medical imaging ecosystem, into PAC system. And so it paves the way for thermal imaging to move from a isolated research area and come to a more mainstream clinical workflow setting. So this is an open source framework that we are developing together. So we would love to invite those who are interested to collaborate with us on adding new features or maybe documentation or any bug fixes. So if you are interested, please feel free to contact us on this ID. Yeah, thank you. And if you have any questions, I'll be happy to answer.
Thanks, Bharat, for the wonderful presentation. It shows that how we can make thermal imaging into the mainstream medical imaging. And it's very critical because as the previous presentation was also showing, it's important to store the emissivity and other parameters, which currently we only have thermal images and metadata separately. I think this framework can be used to tie the metadata and the thermal images and make it medically acceptable. Wonderful presentation, Bharat.
Thank you.
So I will just take the questions. Does the tool allow you to set the packs for thermal image use only? Or only the temperature matrix can be used for DICOM conversion, or can the infrared images captured from thermal camera can also be converted?
Yeah, we support input in CSV as well as in JPEG or PNG in the tool, and you can get the DICOM from that input.
Right. So anyone who is having any kind of JPEG image, PNG image, you can send it and you can define the min and max in the color palette. You would be able to get the temperature values. The current library, we are also supporting direct radiometric images from FLIR as well, which will be released in the next version. The next question is, are there any limitations in the current framework? How can I contribute? Any future work you want, the community to develop?
Yes, yeah, to contact us, this is the ID which you can use. And for some of the limitations, yeah, from the graphical user interface tool, is not as fully functional as through the API. So, for example, like multi-view studies, or it could be like generating the having a color map customization kind of thing. So those are the features we could look at. And we can also think of extending support for some kind of API for PACS integration if that's feasible. Yeah.
Okay, that's great, I think. So yes, I think we will also highlight what are the future work and where we would need the community help. So we would have one README file where we would need your help, and anyone who is interested, please reach out to medthermal.com@nename.com. With this, we will move on to the next session. I hope you all can see my screen. Yeah. So the next session is on deep learning and generative intelligence in infrared imaging. This is chaired by Professor Aura Comsi, who is a computer science department professor in Universidade Federal Fluminense, Brazil. One of the renowned researchers for her contributions to the use of AI and thermal imaging for healthcare diagnostics, improving methods for early disease detection. She co-authored 400 publications with 5,000 plus citations. And we all have seen people using DMR-IR dataset, and she's the one who played a pivotal role in open sourcing breast and thyroid imaging dataset. It's my pleasure to invite Professor Aura Comsi to session 3.
Oh, thank you very much for so kind words, Siva, and thank you very much for this invitation. But I am not the main point. The important point of the section is these 6 very interesting works that came from 3 different continents, from Asia, Europe, and America. So it would be a very multi-continental section. So let's move for the first presenter that will be mentioned. I will talk to you about the first work, a sharply value-based guided feature fusion of multi-branch deep learning for breast cancer screening of thermal imaging. So please go ahead.
So is my screen visible?
Yes, it is.
Oh, thank you. Good evening, everyone. I am Razdeep Pal, a final year undergraduate student from the Department of Artificial Intelligence and Machine Learning at St. Thomas College of Engineering and Technology, Kolkata. Today, I am very much excited to present my research work, a Shapley value-based gated feature fusion of multi-branch deep learning framework for breast cancer screening of thermal images. This work has done by me and my co-author Jyotiraditya Banerjee and under the guidance of our Professor Ram Sarkar. So the most common disease among women worldwide is breast cancer. Over 2.3 million new cases and 6,85,000 deaths were recorded in 2020 by WHO. The survival rates increases to 96% with early detection, but there remains some limitation with the conventional methods. They are the mammography, which are low sensitive in dense tissues, the ultrasound and MRI, which are high cost and limited accessibility, and also the biopsy, which are invasive and not suitable for our routine screening. So to solve these issues comes the thermal imaging. The advantages of this process is that they are non-invasive, radiation-free, portable, and economical. They also detect physiological changes from tumors and are also ideal for resource-limited constraints. Still, there remains some little challenges in the thermography-based diagnosis. They are dependent on handcrafted features, which limits their generalizability. They are sensitive to patient variability and image conditioning, and most CNN models focus solely on the spatial features. And most of them uses a computationally intensive backbones, which limits their practical deployment. Over the past few years, the methods have evolved. The traditional methods include the statistical descriptors and the handcrafted features. Then comes the machine learning algorithms such as the GLCM analysis of the SVM classifiers. Then comes the deep learning approaches such as the CNN, VGG, ResNet architecture. And after that, comes the multimodal approaches. So our approach, in our approach, we are creating a multi-branch hybrid model for spatial and frequency features, a Shapley value-based gated feature fusion for adaptive integration, and a very light-weighted backbone for computational efficiency. For our work, we have used the DMR-IR dataset, which is the database for mastology research with infrared image, compiled at the University Hospital of Federal University of Fluminense, Brazil. It contains thermography examination paired with clinical records of 32 patients with breast abnormalities. The classes present are the healthy and the malignant cases. The image resolutions of this dataset are 640 x 480 pixels. For our work, we have used 80% of the images for training and 20% for testing. So in our proposed methodology, we have used spatial features, frequency features, as well as adaptive fusion. So in our proposed architecture diagram, we can see that we have used 3 branches. For branch 1 and branch 2, we are directly passing the thermal images after pre-processing. And in the branch 3, we are passing the power spectral density transformation, which is the frequency transformation of the thermal image to the branch 3. In the branch 1 and branch 2, we are finding the spatial features. In branch 1, we are passing our images to a MobileNet V3 backbone, which is a lightweighted backbone. In the branch 2, we are passing the same images through a series of convolution and batch normalization layers. And in the branch 3, we are passing our frequency transformed image to a series of convolution and batch normalization. The output of branch 2 and branch 3 are fused with the adaptive Shapley value-based gated fusion, and this output is concatenated with the branch 1's output. The overall output is then sent to our classification head, which consists of a linear and a ReLU block, then a dropout block, and a linear and a sigmoid block. After this, we get a probability, and with this, we are able to classify the healthy and the malignant cases. So, before passing to our model, we have done some image preprocessing, which are the median blur, which reduces the high frequency noise. Then we have resized and normalizes our standard input dimension and also performed a power spectral density transformation to extract the frequency domain features from our thermal images. Then the key advantages of our model are the dynamic weighting based on a feature utility, suppresses the redundant information and emphasizes salient and informative cues. So from the comparison, we can see that our model achieves a perfect score of 100%, establishing a new benchmark. So then after we have provided a GradCam visualization of our model, which reveals the discriminative regions used for classification. For ablation results, we have done studies with the different types of experiments with different types of backbones, feature combination, and also various types of fusion strategies. As our model is providing 100% of accuracy, we have to validate it. We have performed a 5-fold cross validation, and we have seen that for most of the cases, we are achieving 100% accuracy. So there, and in the we have also provided a TSNE visualization, which shows that the two well separated clusters corresponding to malignant and the healthy cases. Finally, I'm concluding my work with the key contribution of our research project, which is the multi-branch framework, a Shapley value-based gated fusion, and a light-weighted backbone, which provides a computational efficiency. Our model also provides a perfect classification of 100% accuracy on the DMR-IR dataset. But there remains some limitation on our work. They are due to the small dataset size, the generalizability is performance on a diverse acquisition protocols not evaluated, and limited demographic diversity in the dataset. So for future work, we can do a dataset expansion, automated ROI segmentation, and a temporal dynamics. So thank you. So if there are any questions, I can answer.
Hello. Thank you. Very interesting your work. And could you put again the figure 4? Your pictures looks very well separated. It's very interesting. Exactly. The group is completely, the feature space for visualization is put that the feature is very well placed. Could you tell him a little bit how do you find so nice position for it?
I think we have achieved such a great result because in most of the cases where I have seen the literature survey, I have seen most of them are working only on the spatial features. So we have also tried to use the frequency features because it sometimes captures some features, extracts some features which are not able to be captured by the spatial domain. I think this combination, and also the Shapley based adaptable fusion is also providing a benefit than rest of the comparison models. I think for these two reasons, our model is performing so great.
And there is also a question in the chat about the 100% accuracy. Can you mention something about it?
Yeah. We were also very much shocked to see this type of results. So that's why we have done this 5-fold cross validation test, and you can see that we are achieving 100% accuracy in 3 of the cases. So I think it might be possible due to our model will work well, but not work 100% for a large data set. I think because the data set is small, that's why, and the generalizability is limited. I think for that reason, our model is achieving a result of 100%. So in our limitations, that it is given that due to the data constraints, our work is providing 100% of accuracy. So in the future work, we want to work, expand our work in the dataset expansion part.
Okay, thank you very much. And if there are yet more questions, put right directly. So let's move to the second talk. Thank you very much. And also let's go from Asia to Europe. And this group is from Spain, from the region of Valencia and Madrid. And the work is an end-to-end GAN and CNN framework for early breast anomaly detection using thermal imaging. Carlos, it's up to you now. Thank you very much.
Okay, thank you. You can see the presentation. Okay.
It's okay. You can try to pass, but I think that it's working.
Okay. Good afternoon, everyone. My name is Carlos Barroso, and I am honored to stand in this Congress. Today, I am going to talk about my presentation, whose this title is End-to-End GAN-CNN Framework for Early Breast Anomaly Detection using Thermal Imaging. Thank you for joining me. I am a PhD student at the European University of Madrid, and I focus data analysis in health and environment for with applied big data and machine learning techniques. The principal researcher is Héctor Espinós. He is the professor of the Universidad Europea Valencia, and he is a specialist in machine learning techniques. With my colleagues, Joan Angulo, Alejandro Pedriguero, Ades de María, Jenny Aguilar, Cesario Tello, Miguel Ángel Torres, Darwin Castillo, Julia, Israel Ramiro. There is a great reserve, and I am learned a lot for them. The context is complex because in the first one, the high geographic dispersion. For example, many rural communities in Ecuador are localized from several hours away from hospital. The second, the territorial is unequal. Health infrastructure is highly centered in Quito or major cities. The third one is several economic contrasts. The difference is important because the mammography equipment or mobile unit is financial insightful in many regions. Number four is social barriers because in some contexts this is relevant for toward invasive screen. So, women with low education or limited access is to healthcare. Then, in discovering to talk about cancer, but it's important because 2.3 million new cases every year. So, with mammography, is the stand it has a limitation because access barrier in low resource setting, but thermography offer an alternative. It's non-invasive and low cost. Important because it's a low cost in Ecuador. So the objective of this presentation is build an end-to-end system that standardized thermal breast imaging to generative synthetic imaging to over data scarcely. And three, train a classifier that clinical can trust. The method is designed to modular, auditable, and ready to plot in clinical workflows. We start from breast thermograph database and build a single clean input screen. Then I depuration and normalization imaging, and I then segmentation the different region of the interest. Continue with the use the GAN because I need a synthetic imaging, and then classificate with CNN. So the classification is important in this evaluation metric, for example, accuracy or road. So I use the database with 218 imaging, and I balance the data. In this picture, we can see the different steps. That in the first one, the theft of the wrong shape in original imaging, to detection of wrong shape in normal imaging, third, alignment of wrong region. So it's the different picture, but the important message is we crop to best only rows. So the algorithm trained on clean signal is important. So in this case, then I have a other problem. So preprocessing include mean and mass normalization. I automated breast rows, detection that priorities, for example, thermical gradient, uh, 128 for 128, and generated for a classification. In the next picture, the problem is I limit for the database because it's a small database. So the solution is cyclogram because I generative relative thermical imaging. For example, when you train the different imaging and the different epochs, the imaging gain morphological coherence and thermical fidelity and downstream classifier. So the result is we evaluate CNN based efficient net B0 and ResNet 15. I explores CNNs and visual transformer, and in the evaluate the precision, accuracy, and road. We delivered the end-to-end combined GAN and CNN make the difference. This message is important. Combined GAN and CNN make the difference. With GAN augmentation and CNN reset 1970% accuracy. So the road boom confirmed a lab gap between model trained without synthetic imaging. So why that this help? No? To conclude, we delivered an end-to-end thermical breast diagnostic pipeline. This is the magic. Conclude, we delivered an end-to-end thermical breast diagnostic pipeline. So with synthetic data leads performance with efficient net B0 and cycle GAN, we observe high accuracy. So clearly outperform model with synthetic imaging is important to the result. So with this, thank you for your attention, and if you have a question, ask them.
Thank you very much, Carlos. Very interesting talk. I wonder. My question is not exactly a question. It's why you work in Spain, and how you show us as an example Ecuador, South America. It's only really a curiosity of mine.
Because in Spain, use the mammography because the result is important and the height elevate, but in Ecuador the problem is different because the inequality or the barrier of social culture and financial is a limit, so it's a low cost. And I collaborate, the important to the relation for your question is I collaborate with the University of Ecuador. So the clinical in Ecuador and is this data for them.
Okay, thank you. There is a question in the chat now. Could you read?
Okay, I can share.
Why did you choose cyclogram?
With amazing sense. And what is the question? With contribution. What? Cyclegan, I use cyclegan because I need to generative synthetic imaging, and in the different case, I prove with other algorithms, but cyclegan is the best result to train the CNN.
Okay, so for more questions, please write in the chat, and Carlos and the others author will answer. So let's move for again from Asia and again from India, now from Calcutta, from Tamil Nadu, and this the work to be presented is customized CNN based on multi-class classifications of children obesity using infrared thermal imaging. So let's move to a different subject from breast to children. Okay, thank you, Risha.
Yes, ma'am.
You can put your presentation, please.
Yes, ma'am, just a moment.
Okay.
Am I visible? Is my presentation visible?
Yeah. You are seeing. Put in presentation mode that it become bigger, and please.
Yeah. Is it fine now?
Perfect.
Okay. So good evening to everybody. I am Dr. Richa, and I will be presenting my work today on customized CNN-based multi-class classification of childhood obesity using infrared thermography. And I'm currently working as a biomedical engineer in AIIMS and GVPN Hospital in Andaman Nicobar. Student of I was a student in SRM University in Chennai, and there I have worked on this project with under the supervision of my guide, Dr. U. Snehalata. So let's move forward with this. So first we will see why this study was actually needed. So childhood obesity is actually nowadays in this scenario, it is rising. The number of childhood obesity cases are actually rising, and it comes with the additional thing of increased risk of diabetes, hypertension, cardiovascular disease, and early metabolic diseases in children. And the current screening tools like BMI, they actually do not reflect the real body fat distribution, especially in children. So, and BMI is seen to actually misclassify obese and overweight children more because of their localized fat accumulation, variation in growth pattern, and metabolic heat changes. Sorry. Problem in clinical practices. So what happens here is some tools are actually not invasive, or non-invasive, are not contactless, and they are not child-friendly tools. And especially it takes so much time, and it's very uncomfortable and sometimes inaccurate for the children's measurement. So why we have used thermal imaging is because thermal imaging is safe, as we all know, and it is radiation free and contactless. So this solves half of the problem which we were facing in the first half. And then the second is the skin temperature pattern actually reflect the metabolic activity and the fat distribution. And despite all this potential, the thermal imaging in children's age group is very limited. The studies are actually very limited in this group. So whoever is interested, they can actually work on this. And then the gap here is like there is no existing AI or thermal based system which provides multi-class classification, like for normal, overweight, and obese children. And then there is lack of standardized thermal data set for children, and there is no comparative, state of the art CNN which is available for the comparative study. So next is objective and contributions for the study. So here we have developed a multi-class model to classify children as normal, overweight, and obese. And then we have used an infrared thermal imaging in two regions, which is abdomen and neck. And then we will be comparing three CNN models, which is ResNet V2, DenseNet 121, and a customized net totally classification of three classes of childhood obesity, and then to evaluate whether patch-based learning improves the discrimination accuracy. So the key contributions of this study is we have developed a lightweight, CNN for this thermal patterns, and then we will be demonstrating the customized programs which gives the highest accuracy, which we will be seeing in further slides. And then we have used a train, validation, and test protocol for the evaluation. So next is data collection and thermal image acquisition. So here we have So here we have collected images from 150 children, and from this 150 children, we have kept equal number of children in each of the classes, which is 50 normal, 50 overweight, and 50 obese. So, and in this 50 also, we have tried to maintain like 25 boy child, and then 25 girl children. So next is that we have obtained an ethical clearance from SRM hospital in Chennai itself for doing this study. And next is imaging setup. So in this imaging setup, we have used FLIR camera, thermal camera for this study, and the room condition was like it was a dark room. So wherever we have windows and huge doors, or wherever there was a light source entering inside the room, that was actually hindered using a heavy curtain, and a temperature controlled room was actually maintained, that is 20 degrees inside the room. And then the distance between the subject and the camera was actually fixed. So our X cross mark was maintained. So where the child will stand, and the cross mark where the camera was actually placed. And then enough time was given for the children to get acclimatized in that room. So two regions which we have used in this study one was abdomen and another was neck region. So image standardization is also like we have used a fixed consistent procedure that which is posture, which is anatomical. So children were actually dressed in a light clothing, and then they were asked to stand on that X mark wearing that light clothing, and then we took the images of both their abdomen and the neck region. Okay, so next is patch extraction. So for each thermal images, we have which was divided into 10 non-overlapping patches. So patch size was actually maintained at 128 into 128 pixels. So this produced a total of 3000 patches, means 150 children, and we have taken images from two regions, which is abdomen and neck, and then into 10 patches. So like this, finally we obtained 3000 patches. That is images which were the data set for our study. So next is like this data set. Why we have used patch based is because it increases the data size, and as it increases, it reduces the risk of overfitting. And then this helped us to learn localized temperature variations in which was linked to obesity more. And we have ensured that both the regions, that is abdomen and neck, contributes detailed thermal information. So region-wise data set handling. So both abdomen and the neck regions were actually kept separately and they were studied separately. And each region, like both these regions, had their own training, own validation, and own test data set. And these models were trained independently for both the regions. So next is the deep learning models which we used for our study. So here we have used Inception ResNet V2, which we have modified for our work, and then DenseNet 121, same we have modified, and we have finally the third model, which was custom CNN model. Then we have a training protocol. So all these models were separately trained for abdomen and neck patches. And then the output activation layer, which was like which divides it into three classes, which is normal, overweight, and obese children. And 30 poaches were maintained for both abdomen and neck region. And okay, so now we have 3000 images in our hand. So from these 3000 images, what we did is we removed 600 images totally for the test set. So this 600 images were never used in validation or the training. It was completely kept separate for testing. So then what happens here is, so 3000 images we had, and then if we separate the 600 images, so we were left with 2400 images. So this 2400 images were actually divided into two parts. So 70% was used in training, and then the 30% was used in validation. And then we have trained it for 30 poaches for all the three CNNs which we have used. So this is the architecture of Inception ResNet V2. So here we can see that the input shape of 128 into 128 into 3 was fed into the pre-trained model of Inception ResNet V2. So here we have STEM and Inception ResNet block and reduction block. So here what happens is all the major features were extracted from here, and then it was given to the global averaging pool, and then it passes through the 512, 256 and 128 neurons, and finally we were getting our result, the classification result. So this part from global averaging pooling till the classification, so this was the modification which was actually attached with the pre-trained model, so that we get completely customized, just for our problem, which is classification for three classes for child obesity. Okay, so next is the DenseNet 121. So here also we can see how DenseNet work is. It enhances features as it moves forward. So what happens is one feature which was used in first block is again used in second block. So here the features get, the features actually it gets very much dense, and then it extracts all the major information from that, and then it was given to the global averaging pooling, and then it passes through all the connecting layers, and then finally we get our result. So this is the architecture of completely customized network which we have used for this study. So here we were giving our input data into the convolution layer. So here we have used 32, 64 and 128 layers, and then it was passing through max pooling so that the size get reduced. And then we passes it through flattened layer so that the output becomes flattened, and then it enters to neurons such as sorry, I'm so sorry. Yeah, then it enters to the dense layer, and then it goes to softmax, and from there it gets converted into three output, which is normal, overweight, and obese. Okay, so here we comes to the result section of this study. So here what happens is, as you can see in this image itself, we move from warmer regions to colder regions. So the warmer part is of normal child, and B is actually of overweight, and C is the abdomen region of obese child. And then D is again the neck region of a normal child. E is a neck region of overweight child, and F is a neck region of obese child. So here we see that there is a consistent temperature drop. If we see, so here in A, we can see that the average temperature which we get is 36.9 degrees Celsius. And then as we move from overweight to obese, the temperature is getting dropped to 32.4 degrees Celsius. So same happens in the neck region as well. So from here, we can see we have 37.2 degrees Celsius, which drops to 33 degrees Celsius as we move from normal to obese. So here and in this table, actually, we can see that in a very, mathematical way. So the p-value is actually statistically significant for all these cases, and we get enhanced result for actually normal versus obese. And that's it. I think I've explained enough in this. So yeah, so why the question arises here is why this, why this temperature gets dropped in obese, from normal to obese. It's because of the subcutaneous fat which is present in obese children and the overweight children. So what this subcutaneous fat does is it hinders the heat dissipation. So wherever there is more fat present in a body, so from there the heat loss will be very less. So if the heat loss is very less, of course that area will become more cooler than the other body part. So this is the reason for the drop of temperature which is seen here. Okay, so next is the performance analysis of all the three CNNs which we have used here, and for both the regions, which is abdomen and neck. So here we can see that the customized network which we created has given us the highest accuracy of 93.1 for abdomen region and 91.6 for the neck region, followed by DenseNet, which has given us 90.8 for the abdomen and 88.6 for neck region, and the last is ResNet V2. Okay, so this is the model accuracy curve which we have obtained. So am I correct? Wait. So as I told that we have used it for 30 approaches. So here we can see that the training and validation which we have performed for ResNet V2 is from A to B, which is of DenseNet 121, and then customized CNN is shown from E to F. So here we can see for customized network itself, E and F, we are getting highest accuracy curve rather than the ResNet V2 and the DenseNet. Okay, so this is ROC curve, and this ROC curve we have just put for our customized CNN net here. So we can see that we have got a ROC of 0.96 for abdomen region and 0.93 for the neck region. So this is the classification result. So overall, we have evaluated 600 test patches. So from this only we have got all these accuracies which we will be looking. So customized net, which is the proposed model here, has provided us 93.1% accuracy, and followed by DenseNet and then ResNet V2. And among both the regions, which is abdomen and neck, the abdomen region has provided the highest accuracy among both those two regions. Okay, and same for the neck regions also. Customized net has actually given us the highest accuracy, followed by both the networks. So if we see that obese class actually had highest detection accuracy than the overweight. So if we see over normal versus overweight and normal versus obese, so this normal versus obese is actually giving us a high accuracy level than the later one. So here we can come to a conclusion saying that this customized network is actually like outperforming the transfer layer models which we have used in our study. And we have actually conducted ablation study also for our study. So here we can see that we have used two optimizers, which is ADAM and ADAMAX, and then learning rate also. So we have used 0.001 and then 0.006, and then we have actually studied the whole thing, like which one is giving us highest accuracy or in which one we are getting accuracy drop. So finally, we came to a conclusion that when we used an ADAM optimizer and with a learning rate of 0.001, so that one, when this is the thing which was giving us the highest accuracy among the rest of the things. So for abdomen, we have got around 93.4, and for neck, we have got around 91.8% of accuracy. So what happens here is, so it's customized network justification, we can give like customized network, the convolution layers, plus the batch normalization, the dropout, and the dense layer which we have used there. So that actually gave us the best balance of accuracy, feature learning, and the computational efficiency. Okay, so there are limitation and future work part in our study as well. So here we have used, only 150 children and from our one community itself. So that becomes like a general study. So, and also we have used only two regions for this study, which is abdomen and neck. Actually, we can go for more regions. And this patch-based labeling may not be fully represent the whole body obesity as well. And then the environment factors. We have tried our best to make that room dark enough to take the images or take the data. But still, there are discrepancies which can happen while taking these images. And in future work, what we can do is we can expand this data set among like across multiple centers, like multiple regions of the body and in different age groups as well. And then we can develop subject level prediction, and then we can combine this thermal imaging with the anthropometric data, and then we can convert it into a new work as well. And then we can combine this, we can combine this customized network which we have made with a device like with a portable device or something which you
Hi,
can
Richa, sorry to
take
cut
the
you. We just because in the interest of the time, let's conclude it quickly.
Yeah, fine. So in the conclusion, I think we have already discussed the conclusion. So that is why thermal image we have used, because it is safe. And in the model performance, we can say that the customized CNN network was actually giving us the highest accuracy than the other things. Okay, I think I'm done. Thank you.
Congratulations. And maybe you can answer the two questions that is in the chat, by the chat as well. Could be, Risha?
Yes,
Could you
ma'am.
write the answer there? And so congratulations. You have done a lot of work and it's a
I
very
know.
interesting application. But please answer there the questions that they write, okay?
Yes,
Could be?
ma'am. Yes, ma'am. Yes,
Thank
I
you
can
very
see
much.
a question. Yeah. So can I answer it here in the chat box or should I be?
Please write
Yeah.
them.
Fine.
Thank
Thank
you
you.
very much.
Thank you.
Congratulations.
Thank you.
So let's move again from America, and the fourth work is AI-assisted multispectral infrared image and robotic telerounding for post-operative assessment using Omni generative intelligence. Okay, who will be the presenter, please?
So Professor Constantly, I think Professor Braiowski is supposed to present, but his flight got delayed. So we will be able to skip the presentation. We should be skipping the presentation. Yeah.
You skip.
Yes,
Let's move
that's
to this. Let's move to the 5th one. Okay. So it will be multi-view thermal breast imaging for malignancy detection performance benchmarking for CNN transformer and evolution architecture. This presenter will be from Istanbul, and please go ahead.
Thank you. Let me share my screen. Can you hear me?
Yes, we can hear you.
Yeah. Okay. I'm sharing. All right. I hope it's visible, so I can start. It's visible?
Yeah, yes.
Okay. I'm starting. Hi, my name is Mücahit Cihan from Konya Technical University, Department of Electrical and Electronics Engineering. This talk presents our work titled Multi-View Thermal Breast Imaging for Malignancy Detection. Together with my colleague Murat Ceylan, we benchmark CNN, transformer, and emulsion-based harmonic light architectures on breast thermography. I will briefly walk you through the dataset, the pipeline, the models, and the main findings. In this presentation, I will first give the motivation and clinical background, then summarize our objectives and main contributions. Next, I will describe the dataset and acquisition protocol, the overall workflow pipeline, and the ROI segmentation strategy. I will then cover preprocessing and augmentation, followed by the deep learning architectures and the training protocol and evaluation setup. After that, I will present the quantitative results and a short discussion on why emulsion helps. Finally, I will close with the conclusion and future work. First of all, motivation and clinical background. Breast cancer remains one of the leading causes of cancer-related mortality in women, and early detection is crucial for survival. Conventional mammography has limitations, reduced sensitivity, intense breast ionizing radiation, and patient discomfort. Infrared thermography, in contrast, is non-invasive, radiation-free, portable, and suitable for frequent monitoring. However, raw thermographies are difficult to interpret consistently. Their diagnosis value strongly depends on robust, well-designed computer-aided diagnosis systems. These need motivates the work I am presenting today. The main objective of this study is to design and evaluate a static multi-view breast thermography classification framework. First, we built a complete pipeline that uses anterior and oblique thermal views and performs benign versus malignant classification. Second, we perform a fair benchmark of 3 model families under the same protocol: CNNs, transformers, and the involution-based harmonic light. Third, we adopt patient-wise stratified 5-fold cross-validation on a public dataset to avoid data leakage. We use the public breast thermography dataset. It contains 119 patients and 476 manually segmented regions of interest. or ROIs. Each patient has up to 3 anatomical views: anterior as A, oblique left as OL, and oblique right as OR. Images were acquired using a Fuller A300 thermal camera under controlled temperature and humidity conditions following standard thermography protocols. Diagnostic labels are normal, probably benign, and probably malignant. For this study, we formulate a binary problem. We merge N and PB as benign and plus PB and use PM as malignant. We choose. This slide summarizes the overall workflow of the proposed study. We start with data collection from anterior and oblique thermal views. Then we perform manual ROI segmentation for the left and right breast. Next, we apply preprocessing and data augmentation to obtain standardized and diversified inputs. These ROIs are fed into different deep learning models. Finally, we carry out training and patient-wise evaluation within a 5-fold cross-validation schema. Each subject has anterior oblique left and oblique right views. We split the anterior image into anterior left and anterior right. ROIs, anterior right ROIs. Oblique views give OL and OR directly. We use manual segmentation to get precious breast boundaries and remove background like shoulders or neck. In total, we obtained 476 ROIs for training and evaluation, ensuring the classifiers focus strictly on breast tissue. Here you can see examples of our multi-view ROIs. The top row shows the original anterior oblique right and oblique left thermograms. In the bottom row, we manually segmented the breast regions. The anterior view is split into right and left ROIs, and the oblique views provide single breast ROIs. This manual segmentation removes the shoulders and background also and forces the models to focus only on the breast tissue, which is critical for reliable classification. For preprocessing, we convert grayscale ROIs to RGB, normalized to 0, 1, and resized to 224 times 224 for complementary with pre-trained backbones. During training, we apply online augmentation, moderate rotation, translation, zoom, and horizontal flip. We also add center crop cutout, about 25%, small Gaussian noise, and mix up for regularization. These steps increase variability and reduce overfitting while preserving the core thermal pattern. This slide illustrates our preprocessing and augmentation steps on a single ROI. During training, we apply moderate rotations, translations, zooming, and horizontal flips, as well as center crop cutout of about 25% of the area, small Gaussian noise, and mix-up. These operations increase variability and reduce overfitting while preserving the underlying thermal pattern. For CNN baselines, we use ImageNet, pre-trained DenseNet 121, Inception V3, and ResNet 50. DenseNet has dense connections for feature reuse. ResNet uses residual blocks to ease optimization, and Involution version 3 applies multi-scale filters to capture different receptive files. For transformer, we evaluate SwinTiny and WithTiny. SwinTiny uses shifted window self-attention for efficient local context, while WithTiny is a compact vision transformer with global self-attention over patch embeddings. All batch bonds share the same lightweight head, global average pooling, and plus sigmoid for binary classification, as well as identical preprocessing, augmentation, and patient-wise 5-fold cross-validation for fair comparison. HarmonyNet Lite is our main contribution, a lightweight HarmonyNet variant tailored to thermal breast ROI classification. It replaces many convolutions with the involution operator, which generates content-dependent, spatially adaptive kernels at each location to better capture subtle local temperature gradients and low-contrast thermography structures. The model forms a compact hierarchy of involution residual blocks with progressive downsampling followed by a simple classification that despite having only 0.4 million trainable parameters, it still outperforms heavier CNN and transformer baselines, making it ideal for edge-friendly high sensitivity screening. We evaluate with patient-wise stratified 5-fold cross-validation, K equal 5, ensured that rows from the same patient never appear in both training and validation or test sets, so there is no data leakage. To handle the benign malignant imbalance, we apply controlled oversampling of the minority class, mix-up augmentation, and optionally a class-weighted binary cross-entropy loss. All models are trained with the AIIMA adaptive momentum optimizer, binary cross-entropy, batch size 16 for up to 100 epoch. We monitor validation, AUC, area under curve, and use early stopping plus reduce LR on plateau to reduce the learning rate when improvements stop. For each model, we report accuracy, precision, recall, and F1 score as mean plus or minus standard deviation across the 5 folds. This table summarizes the mean plus or minus standard deviation performance of all models. HarmonyNet Lite achieves the best overall scores, accuracy of about 87.47 plus or minus 2.99%, recall 93.33 plus or minus 2.13, and F1 score, as you can see, 68.43 plus or minus 8.75. Among CNS, ResNet 50 is the strongest baseline with around 85.59 plus or minus 3.37 accuracy, and 63.16 plus or minus 3.87 F1 score. Among transformer with tiny is competitive, while simultane lacks mainly due to lower precision. DataSet 121 shows the weakest performance, especially in precision. Overall, HarmonyNet Lite outperforms all CNN and transformer models in terms of accuracy, recall, and F1, despite having far fewer parameters. High recall is partially important in screening, where missing malignant cases in unacceptable. This figure summarizes the overperformance of all models among the CNS and transformers. ResNet 15 and 50 and with tiny are the strongest baselines, but HarmonyNet Lite, our model, HarmonyNet Lite clearly gives the best results with the highest accuracy, recall, and F1 score. So despite having far fewer parameters, the involution-based model outperforms the heavier architectures, which is very attractive for screening and deployment on resource-limited devices. Let me briefly discuss why the involution-based approach helps. First, spatially adaptive kernels allow HarmonyNet Lite to focus on fine local thermal gradients, which are crucial cues for malignancy in low contrast thermograms. Second, the model can better suppress irrelevant head patterns, for example, from shoulders or neck regions that might remain near the ROI boundaries. Compared to others, HarmonyNet Lite achieves higher recall with significantly fewer parameters, indicating a favorable trade-off between complexity and performance. It is inductive bias driven by content-dependent filtering, matches the characteristic of various thermograms, and makes the model suitable for resource-constrained portable devices. Here I conclude and outline future works. We proposed a multi-weave thermal brace CAD pipeline with CNN transform and HarmonyNet Lite models. HarmonyNet Lite gives the highest recall and strong accuracy with only 0.14 million parameters, showing that involution-based spatially adaptive filtering is well suited to subtle thermal cues, and that lightweight models are promising for screening in low resource settings. Going forward, we play multi-center external validation on larger cohorts at automatic unit-based ROI segmentation, extend to multi-class and multi-model image plus clinic metadata settings, and explore hybrid involution attention models with thermography-specific GAN augmentation to improve robustness and reduce data scarcity. We would like to thank the contributors of the breast thermography dataset and the AIIMA organizer for providing this platform. This work was conducted at Konya Technical University from Turkey. If you have further questions or would like to collaborate, please feel free to contact me at this is my email address. Thank you very much for your attention. I'm happy to take any questions.
Thank you very much, Sihan. There is one question for you, and as we can see, there is a lot of things happening in the chat for all the authors before. But for you just now is if you use PNG image in your work or you use a temperature matrix directly.
I don't understand.
Because you show us image. You use the image directly, or you are use the thermal data?
Yeah, I use the original image. We use that. We have three class anterior and oblique left or oblique right images. We take that ROI selection. We use ROI selection, manual ROI selection. Before manual ROI selection, we use UNet, but it is not improve our results. After that, we use original thermal image.
Okay, thank you very much. And so answer for the other questions in the chat, please. Okay. So let's return to America for the work of that will be presented by Lenny. Is it? You can put your presentation, Lenny, and while I'm mention the name. And the presentation is video transformer for dynamic breast infrared image classification. It's up to you now. We are not seeing yet your okay, it's up here. Go ahead.
Greetings, everyone. Can you acknowledge if you can hear me?
Yes, we can hear you.
Yes. Okay, good. Thank you. So I'm presenting this research work. Today's agenda will be divided in 4 parts: the introduction, the methodology that we use, the experimental results, and some conclusion. In this part, I'm going to be brief, since I think we are kind of aware of the impact of breast cancer and also the limitations of mammography as the gold standard exam that is commonly used to address breast cancer, and the importance of early detection. The same, the importance of thermal or thermography, it has already been talked in this conference. So what is important here is that we address 2 different protocols to acquire the thermographic image. These are the static infrared thermography, or SIT, and the dynamic infrared thermography, or DIT. Here we have an image of a patient. The importance of the protocol of the dynamic infrared thermography is that it applies a stress to a patient, and it tries to highlight the vascular behavior after that stress. So it captures an image every 15 seconds in 5 minutes. This produces a total of 20 images that I'm showing to you here for the 650 patient case. These are actual temperature maps. So in this paper, we made the following contributions. We extended the vision transformer approaches to the dynamic protocol. According to our literature review, there were no current studies addressing transformers and dynamic protocol. Next, we evaluated the role of fine-tuning. Does it help to improve the models, especially when dealing with vision transformers, limited data, and large architectures? We conducted the experiments making or addressing a difference between the temperature matrix and the infrared images. Finally, we introduced the video vision transformer. We work with the time transformer, and we achieved the report AUC score. And there is also the number 5 is mostly a conclusion that we'll address later on this speech about the relation between the spatial vision transformer and the video transformer itself. So the proposed research questions are related to the contributions. We will deal if vision transformers outperform convolutional-based architectures, what is the role of fine-tuning, and do video transformers, which would merge the spatial and temporal features of the problem, will help to the DIT protocol. So our methodology consisted in the 7 stages that are mentioned here, from problem formulation to model evaluation. These were applied to all our experiments. It's important to notice that the data set that we use is the DMR-IR from the UF University. And we experimented both on the temperature maps and the infrared images. It's important also to notice that when addressing the total sequence of images by patient, our analysis unit is the patient. The task here is a binary classification, so we're going to be addressing 20 sequences of images or 20 sequences of thermal maps to the model to process. And the preprocessing basically was the resizing to 224 by 224 size of the image or of the thermal map, the normalization accordingly, and data augmentation during training. For validation, we use the tenfold cross validation, and also we reserved a 10% stratified holdout for further testing in order to see how much we can generalize our results. And here in this table, we can see the main differences between the temperature map and the infrared image. This is because we were thinking that probably transformers will work better on infrared images because pre-trained transformers work on natural images. And the temperature map, it is different nature. It has float values because it records the temperature of the body. The models that we evaluated are 3, the time-distributed layer model, which was a proposal so we can address something based on convolutional neural networks and recurrent neural networks. So Keras has a time-distributed layer that allows to share the weight across all frames and apply the layer to every frame. So it was kind of interesting to see what happens there. This was tested with temperature maps. Then a modified vision transformer, which uses mainly a spatial architecture, but loads all the 20 frames into its input. And finally, the video transformer to account for the sequence for both space and time inference. So here we have a description of the architecture that was proposed for the time-distributed layer model. We can see that this is small with 7,000 parameters, and it is working with a single-channel temperature map. And here we have a representation of the architecture proposed for both the basic vision transformer, which is the Dosovitsky design, basically, only with the difference that we are loading the 20 frames. And for the video transformer, here we selected time transformer because it was the most appropriate for the hardware available at this moment. And it has a limitation because it processes only 8 frames. So I selected randomly from the frames, but respecting the order or the sequence until I obtain the 8 frames. We can also see that there is a heavily increase in the number of parameters from the vision transformer in the order of 86 million, and the video transformer increases even into the 121 million parameters. In this slide, I'm presenting to you the different experiments that we carry out in this research. We have the thermal map dataset that work basically with a time distributed layer. And in the thermogram images, we work with the video transformer and the modified vision transformer. In the modified vision transformer, we address what happens when we start with pre-trained values or with a scratch. And also we address what happens if we change the patch size or increase it. And all the results are reported in this case with a 1 score and the 10-fold cross-validation. We can notice that in 32 by 32 we achieve perfect score, but we have to acknowledge that there is limited data in this problem. Here we present further results of the experiments in the 10-fold cross-validation and the performance on the test set. This was interesting because different to other authors, they only relied on the 10-fold cross-validation, and we can say that vision transformers may outperform the results. Especially, we had a previous work in the related literature by Matthews de Baffa. He was working with 3D convolutional neural networks. Video transformers, I may say that they are promising. They may outperform 3D convolutional neural networks. And another related work was that of Garia et al., but that one differs in the protocol use. It is basically the statistical protocol they use. We haven't managed to outperform that yet. So as findings and discussions, we noticed that the cross-validation of the time transformer achieves similar performance with respect to Matthews Buffa, but different to their work, we work with a bigger resolution, and also we do not use a segmentation of region of interest, which is something that the others do. And we acknowledge that there is a risk of overfitting due to the data size and the large architectures, but fine-tuning is working to mitigate it. So according to our questions, do VITs outperform CNNs-based approaches? We may say that they are promising. Fine-tuning is better than Scratch. We may say that in this research, it happens. Fine-tuning does better. However, Garia et al., they reported that training from Scratch worked better for them, but there are conditions that are different between their work and ours. And about the video transformer, I think this is a good initial research, but further research is required. For instance, we are only using 8 frames, so it would be great to try to test other video transformers that have more frames, or even one made to the 20 frames that this problem requires. So we presented a video vision transformer. We think it's the first study applying that into the DIT protocol. The performance is state-of-the-art or achieving a state-of-the-art. We demonstrated something about fine-tuning and how it is necessary to mitigate overfitting. Also, we may say that it was really hard to work with the temperature maps and the time-distributed layer. So it seems that pre-trained models work better with infrared images, maybe because of their nature. So further research is needed to investigate more about the temporal dynamics in DIT with the video transformers. Thank you, and I will be glad to answer any questions you may have. Aura, your microphone is off.
Exactly, sorry. Congratulations for the presentation
Thank you.
and for the big work you have done. But maybe they send the questions for you email after. And so because you have yet a film, isn't it, Siva?
Okay, it's fine.
So
Thank you.
I pass it to you, Siva, for the movie of Professor Marcus
Yes.
Briosky and the end of the conference. Thank you very much for all of you.
So what we'll be doing, Professor Briosky's presentation is close to 40 minutes, so which is not suitable for this presentation mode. I would be sharing the video here. Please feel free to watch the entire video. Now we will move on to the next session, the closing session. Just give me a second. Let me know if you can see my screen.
Yes, perfect.
Thank you, Professor Consi, for having the wonderful session 3. With this, we move on to the final session, closing remarks. It has been a wonderful conference with insightful presentations, thoughtful discussions, and cutting-edge research. We have seen presentations on how interpretable and explainable AI techniques are applied to breast cancer detection, orofacial classification, and even sports injury. We then discussed about how deep learning techniques have been helpful in improving the breast cancer detection and also childhood obesity. We also went through the open source resources that are upcoming, where we have seen people working on med-thermal DICOM to standardize the image saving. And we have an open source resource on how 3D surface, 3D breast surface reconstruction. The breadth and quality of work shared today demonstrate how rapidly this field is evolving and how strong, collaborative, and innovative this community has become. I would like to thank the session chairs for making all the sessions engaging. A special highlight of today's program was a keynote talk from Professor Prathosh, who delivered a compelling introduction to generative AI in medical imaging. His session provided valuable perspective on the foundations of AI, outlined the challenges we must address, and the future direction that we could focus in medical imaging. Across all the sessions, one message stands out clearly. AI applied to infrared imaging is emerging as a powerful, safe, accessible, and radiation-free modality, one that can reach the remote areas, clinics, and communities, and potentially even homes as well. There are only few imaging modalities which could offer such portability, privacy, and physiological insights. The work presented today shows that how transformative this can be for global health. I would like to extend my sincere thanks to all authors who have presented to this year's conference. We have received a total of 23 submissions, and after a peer review, we have accepted 13 papers whom we have seen the presentation, and all of these are published in LMCS. Thank you all authors for submitting, for considering your submission into AIIMA 2025. I would like to thank the reviewers who took their time and provided valuable feedback and suggestions to authors to improve their manuscripts. This wouldn't have been possible without the support from organizing and program chairs with their consistent guidance and vision. I would like to thank LMCS for publishing the proceedings. The proceedings publication is almost done. You would be able to find the proceedings in this link, most probably from Monday. Once the proceedings are available, we will share the PDF version with all the participants, along with the recording as well. We would like to thank Niramai, our event sponsor, who has been providing consistent support in terms of marketing and also giving us a platform to host the conference. With this, I would like to end the conference with two closing thoughts. First, saving lives with equitable healthcare. We have seen how the fusion of AI and infrared technology can help detect diseases earlier, enable non-invasive screening, and improve patient outcomes across the world. This field has potential to make healthcare more accessible, affordable, and equitable than ever before. The second thought is on continuous innovation. Let us continue pushing boundaries, collaborating across teams, across disciplines, and building solutions that create meaningful global impact. The progress shown today is just the beginning. Thank you for your invaluable contributions, inspiring presentations, and unwavering dedications. Thank you once again for being part of AIIMA 2025. We look forward to meet you all in AIIMA 2026. Thank you all. Thank you, Professor Kansi. Yes.